I just saw the little icon go on.
Okay, great. It's still loading on my end. Okay, we are live. You're ready to call the meeting to order.
All right, let's do it. I'd like to call this meeting of the Patient Protection Commission to order and have Ms. Mayville call roll, please.
Thank you, Chairman. I will start with our voting commissioners. Dr. Packham,
Here.
Dr. Barron,
Here.
Teresa Bohannon,
Here.
Bobette Bond, Bobette,
Is muted.
She's here.
I thought I saw her a minute ago. Okay,
Here, sorry.
that's okay. Jessica Flood,
Here.
Flo Khan,
Here.
Dr. Khan,
Present.
Yarleni Roa Dugan,
Here.
Sean Shaner,
Here.
Dr. Slonim,
Here.
Mason Van Howling,
Present.
and moving on to our advisory commission members, Heather Korbulik,
Here.
Barbara Richardson,
Here.
and Richard Whitley.
Here.
All right, Mr. Chairman, that concludes our roll call and we have a quorum.
Outstanding. As we begin, I'd like to gently remind my fellow commissioners to mute your mics when you're not speaking. And I think what worked really well last time is if you have a question or a comment, just raise your hand and I'll try to recognize you in the order that you raise your hands. I'd like to now turn to agenda item 2, and that is public comment, and invite those who would like to provide public comment on this. I would like to ask, though, if you are speaking from a patient's perspective or your experience as a patient during the current pandemic, I'd like for you to hold off until agenda item 3, in which we're asking individuals to present their experience over the last 6 months as it relates to COVID-19. So Sarah, if you'll help me, I think we're ready for public comment.
Great. First, attendees, if you can, let's just take a moment. Anyone who is attending, if you would like to raise your hand now, this is the time to indicate that you're here for public testimony. If you're on the phone, you can raise your hand by, I believe, pressing *9. Let's just make sure. And so let's give and we will call on folks who are not speaking on behalf of patient testimony, and then we'll move on to patient testimony as Chair Packham indicated. Leslie, is there any public testimony to read into the record?
Not at this time.
All right, Mr. Chair, if you want to just wait about a minute just to give folks a chance to indicate. We have a decent amount of attendees. I am not seeing any hands raised right now for non-patient testimony.
Shall we move on to agenda item 3?
Yes, I don't see anybody raising their hand for testimony.
Okay, very good. Well, let's move on to agenda item 3, which is a presentation from patients about their experiences with COVID-19 in Nevada. And I do know we have at least 1 or 2 lined up.
Okay, I'm going to call upon Ashley first. Ashley, asked to unmute and.
Good morning.
Good morning.
Morning. Good morning, everybody. My name is Ashley, and I was asked to speak today about my experience as a patient in Nevada's healthcare system for about the past 3.5 to 4 years. I would first like to thank Sarah for allowing me to speak today and to share my story, and thank all of you for taking the next few minutes to listen. On May 19th, 2017, I gave birth to a beautiful baby girl via C-section. I was sent home 72 hours later, and my recovery was very hard. Knowing I had just had major surgery, however, was my excuse for losing 35 pounds in 3 weeks, being ghost white in complexion, not having an appetite, becoming physically ill to my stomach, and being just exhausted. My incision had opened in 3 spots, and I had a thick band of red inflamed skin above it. I sought advice from my OB several times because it just didn't seem right, but was told to just take it easy. On June 4th, I remember telling my mom my chest was burning, like a smoker's cough. Having felt so weak and ill in my recovery to this point, however, I chalked it up to something else. Over the next 48 hours, things declined rapidly. By June 6th, I was unable to lay down due to the excruciating pain in my left shoulder. I couldn't catch my breath, and I felt like I had an iron ring around my chest that was getting clamped down tighter and tighter by the minute. At the urging of my husband, I finally went to the ER. After giving my symptoms, I was brought back and given a CT scan, and not 20 minutes later, I had a flood of people in my room telling me I had a massive pulmonary embolism in both lungs. My mom and the hospitals talked about doing TPA, but decided that with the risk, they would just start the heparin drip. Shortly after the doctor left, I distinctly remember a nurse saying she wished she would have done the TPA so the clots would have broken up, because worst case scenario, I would have died, but they could have brought me back. It was absolutely mortifying. After 18 hours in the ER, I was finally admitted. My diagnosis was massive pulmonary embolism, postpartum cardiomyopathy, sepsis, pneumonia, enlarged spleen, and I also had to have 2 blood transfusions due to my hemoglobin level getting so low. I was hospitalized for a week and then finally discharged. To keep the next part of a very long story short and to provide context for the experiences I'm going to share, I was eventually diagnosed with triple positive antiphospholipid syndrome, a rare autoimmune blood clotting disorder. In the recent months, I've also been told I have lupus. I have suffered from PTSD, anxiety, and panic attacks, which honestly may be the hardest part of my journey to manage. But I've remained resilient and strong and continue to fight each day for my family and for myself. My healthcare team right now consists of a primary care doctor, hematologist, rheumatologist, neurologist, gastroenterologist, cardiologist, ENT, and a therapist. As mentioned, over the last 3 years, I've seen a multitude of specialists for my autoimmune disorders and chronic dizziness that we have yet to find a reason for. While I have a great team of doctors now, part of my experience is what it has taken to get there. I've seen a combination of 14 doctors to find out who is familiar with my diseases and my symptoms. At one point, I waited 7.5 months to see one specialist. I had used the networks that I've worked so hard to build for my career for personal use to try and get into 2 other specialists. Otherwise, it would have been another 6 to 8 months to get appointments. Testing done by my neurologist to try and find a reason for my wooziness took 2.5 months for all of the appointments, to be told it's in my head, and to get on an antidepressant. I've had to advocate for myself and provide literature and research to my hematologist to not use finger stick machines for my INR readings because they aren't accurate, and that I need to be on warfarin because the new DOACs aren't approved for the management of my disease. My specialists often don't communicate as a team, so I've had duplicate labs done, unnecessary appointments, have been asked far too often, why did your doctor order this, or what did your doctor say about this, or you should ask them about X, Y, and Z. I'm left frustrated, wanting to beg them to talk to each other as trained doctors and not put me in the middle as a patient. I've sought out a concierge primary care physician, someone that responds to phone calls and requests in a timely manner so I don't have to wait so long for appointments. What has allowed me to focus on finding the best care and where I know I am blessed is having good insurance. My medical bills have cost hundreds of thousands of dollars before insurance, and even after I've spent well over $10,000 on my medical care. But I know these fortunes of mine aren't the reality for most. I see daily in my career, through my family and friends, and from stories from my colleagues, the detrimental impact lack of access and financial means to get care can have. This, along with my personal experiences, was the catalyst for me to join Comagin Health's Patient Family Advisory Council so I can help with the patient experience. I want to touch quickly on the impact of COVID-19 on the access to my care. My appointments, like many other patients, have been switched to telehealth, including phone and video. While yes, they are convenient to me as a working mom, I miss having the human connection of the patient-family or patient-physician relationship, and they are difficult to manage. I do believe that there are a lot of advantages and challenges to work through as we consider how healthcare may look moving forward. My experiences have come full circle in my day-to-day career. I am currently the director of the Pre-Professional Advising Center at UNLV. My job is to help undergrads become competitive applicants for medical, dental, PA, PT, pharmacy, occupational therapy, and optometry programs. I now intimately know the need for more physicians in our beautiful state to serve our population, especially those most vulnerable. And I am more motivated than ever in my career to help my students achieve their goals and come back to Nevada for their careers and maybe even find a cure for my disease. I want to thank you for taking a few minutes to listen to my story. I know it was long-winded, but there's so much more that I could say, so many more stories that I could tell. I am incredibly grateful this commission was formed, as the patients in our state do deserve the best care. As we move forward, I am happy to help. Thank you.
Thank you very much for that testimony. Sarah or Leslie, do we have anyone else?
We don't. You can open it up for questions too, Mr. Chair. If there's anyone who would like to ask Ashley any questions, this is the opportunity to do so.
Sure. Any commissioners have any questions? Teresa, then Flo.
Thank you, Chairman. Thank you, Ashley, for telling your story. It takes a lot of courage, I think, to put yourself out there and explain the complications of the healthcare system. I share in your frustration as being a parent with a child with a complex medical conditions and understanding those communication issues. So I just really want to say thank you. I am curious, is all of your care currently in Nevada, or have you gone out of state for like a higher level of care?
Thank you. I have stayed in Nevada. I have been referred over to California, and I've also referred to Mayo, but I have not followed up on those appointments. We're at a point with my current healthcare team, as you heard, there's a multitude of specialists, and part of how hard I've worked in order to find that team has allowed me to feel comfortable with the specialists. I still don't have an answer to this wooziness that bothers me on a daily basis, but I'm still able to function. And so I have not gone out of state yet. I'm a true believer that we have really good doctors here and that they will find something to help. And so far, you know, the team that I have put together has been wonderful in providing the care individually. So no, I have not gone out of state, even though I've had the referrals to do so.
Hi, Flo, I believe you had a question.
Thank you. So thank you, Ashley, so much for also sharing your story. Just a quick question from your own experience. What would be one or two things that you would like to see changed that you think would help you get to a better, maybe not resolution, but a better outcome in terms of your care?
So I think the first would be touching or reiterating what I did touch on in just a little bit better communication between my specialists. I often find myself, especially between my primary care, my rheumatologist, and my hematologist, having the lupus, and then of course APS being an autoimmune based disorder. Those are probably the three that I communicate with the most. However, that has also led to a lot of duplicate labs. Hematologists will run a set of labs, and then I'll go to the rheumatologist, and while they run some different, they run quite a bit of additional. And I feel like with a complex disease such as APS, which is very rare and not studies as much as we would like, it's not becoming as rare, but I just feel like if they were to be in a little bit more communication with each other, you know, coordinate labs or coordinate care, or if I do add an additional medication, I don't have to follow up with the hematologist about INR. And so I think that would probably be the first thing that I would really appreciate, so I know that when I go to each of those appointments, they've been in contact with each other about how to best manage my diseases. And I think secondary to that, you know, and I know that it's going to just take more doctors coming here, but and not waiting so long to get appointments with these specialists. As I mentioned, just with one of my rheumatologists, it was 7.5 months to get an appointment. I use social capital again with a few of my other specialists that I went to see, just connections that I had built for my career. I used to work for UNR Med prior to moving over to UNLV. And so I reached out to the doctors that I knew to try and get in for those specialists. So again, I realized that's the solution to that is to find more great doctors to come. And again, that's why I'm motivated to do my job so well, to get our students to come back here and be physicians. But you know, it is excruciating to have autoimmune disorders, to not feel well and then call and be told, well, it'll be 7.5 months before we can get you in for an appointment. So
Dr. Packham, I've got a comment.
Yeah,
Or a
Jessica,
question,
go
maybe.
ahead.
You know, this brings up the whole issue of the EHR, correct? I could be off, but it seems like what she's looking for. I mean, is that goal of multiple providers being able to look into someone's record and being able to have that centralized view and coordination in one place, correct? Like, can everyone say yes, that's what it is? So I'm just wondering, I mean, I know that this is idealistic, but like, how do we get our EHR to work in Nevada? And could that be part of our work plan? I guess I was just kind of, you know, could we see what barriers are happening? I think that this is this ongoing thing.
Absolutely. Howard.
Mr. Chairman, is my understanding that was part of the ACA, but it still has like a failure to launch?
Yeah.
Mr. Chair, this is Mason. I think Jessica's right on. This certainly would help expedite care and reduce cost overall, and help with sharing information. And you know, Dr. Sloan and I and UNLV share the same Epic electronic health system, but as the physicians know, and I feel for them, they've got multiple logons, multiple passwords, and they don't often connect together. And we do have an initiative here in the state called the Health HIE, which is the Health Information Exchange, but just didn't quite take off the way it probably should have. And we don't have full participation, but I think Jessica's right on. That would certainly help with some of the expediting of care and reduce duplication, and also drive out some of the waste and costs that exist in our state. So good point, Jessica.
Okay. I think Howard has a question or comment, then Bobette.
Sure. Just a comment on what you're talking about. I was going to ask Ashley, actually, as a member of the Comagin board, I know that Jerry Reeves, who directs that, is integrally involved in the Healthy Nevada aspect. And one of the things that Jerry always preaches to us is that Nevada is one of the states that you have to opt in order for your data to be in the Healthy Nevada registry, and that has really curtailed or limited the ability of the exchange to be very effective. So there's a lot of states that have passed opt out legislation, and maybe that's something this commission could look into as a way in which to enhance the automaticity, so to speak, of people's data being able to be in. You can still opt out, but rather than having to volitionally sign paperwork that opts you in, as a physician who would rely on that data, it's not very helpful to me if most of my patient's data is not in there because somebody didn't complete paperwork.
Thank you, Howard. For the record, Jerry's approached this commission about presenting, so I will leave it up to the commissioners, but it's on our radar screen. Bobette?
Yeah, I have probably 3 comments about the HIE conversation. I was part of the original state HIE board that got federal money to try to create an HIE in the state of Nevada. And it was disbanded after, in my opinion, there was an approach to make the HIE a private sector solution. And I think before we decide that there's an HIE solution, I think that this board should be much more aware of who owns the HIE, who owns the data that goes into the HIE, how complicated it is for a patient to opt out of HIE, and their private health information is distributed in this system that is not owned by the state. It's a private sector solution. And so all this data goes into, I believe it's probably Optum in the end, but I would love, I would love to have a more complete conversation about this, but I think the barriers to changing opt-in to opt-out would have to, in our opinion, for our support, have to ensure that this is a state system, not a private system, and it's not going into a database that then can be monetized, and then patients' records are captured without a lot of their understanding of it, and that is not what's happening in a lot of other states. So my third comment is, federally, there's been a high-tech law that's passed to ensure that every EMR in the state can be interoperable. So I feel like we should be working on that instead of a subscription service where we put all the data in a private database that then people have to pay money to access. I think that what we should be doing is making resources available to help with interoperability among everybody's existing system, and not, I feel like the HIE is probably yesterday's solution. Dr. Packham, you're on mute.
I wanted to just see if the commissioners had any last questions for Ashley while she's still here.
I have a comment, Dr. Packham.
Yeah, go ahead,
Or
Yarden.
a question for our guest speaker. I would like to know what kind of insurance or insurance coverage you had, and if that made it easier or harder for you to get your care. Was that one of your worries, if your care was going to be covered by your insurance?
So as mentioned, I work for UNLV. My last 12 to 13 years of my career has been with the state through Nevada State, UNR Med, and then with UNLV. So I'm on PEBP or Health Scope through the state. And the great thing about that is the non-necessity of referrals for specialists. If I've had to have a referral, it's been because the specialists themselves or the office requires a referral from the primary care. But as I mentioned, in seeing a combination of 14 doctors between all of those specialists, where I know I'm fortunate is that my insurance allows me to call up these offices without a referral unless they need one to try and get an appointment and to try to get care. I realize I'm very fortunate in that my insurance is good. My deductible and what I pay out of pocket is minimal compared to most. So it has not been hindering me to try and find care, but I also have a very solid support system in my family and my friends who will not allow financial to keep me from getting answers and the care and this, with the specialists that I need. So they're behind me 100% to try and provide that support, whether it be monetary or else to help cover some of those bills. But I've become a master budgeter within my family in the last several years to try and cover the care and the costs associated even with what I'm left with as far as out of pocket. So I do realize, as I mentioned in my remarks, that my insurance is very good compared to a lot of others. And I have not let it stop me from care, but I also realize that financially I have a lot of support that allows me to pursue the specialists that I feel like I need to see.
All right, any other questions? Teresa.
Just a quick comment on this conversation about the cost of care, and something that Ashley said that I want everybody to maybe sit with for a minute was that she said that she was fortunate, even though she's had tens of thousands of dollars worth of out-of-pocket expenses. And I can attest to the same thing. I have good insurance, but it still costs a lot of money. And the fact is that we're saying that that's fortunate. I think that's criminal in a country with the kind of resources that we have. So I just want everybody to sit with that idea. While you have insurance, you have access to specialists, you have, what you feel is good care, you're still burdened with out of pocket, out of network, all these things that cause a lot of stress for people. And that's the untold expense of medical care in the United States of America, is not knowing what an unexpected bill might be, and that feeling in your gut when it drops your heart. So I just want everybody to understand that. And thank you, Ashley, for sharing that.
Bobette.
I'd just like to follow up. Yeah, Ashley, it's great that you're here. It's good to hear from patients that have a lot of access and the patients that don't. I think that something I've asked for in the last couple of meetings, and I'm just going to say it again because I think it's germane to what we're doing here today, right now, is hear about WebIZ. If there's pieces of the WebIZ system that could be used to integrate some of the information we're talking about, or to better line up, particularly the coming COVID issues of who's positive and who's got the antibodies and eventually the vaccine, and any other related items that Ashley's testimony helps support. It would be great if DHHS could do a presentation on what's going on with WebIZ. It's a tool that exists, and it is one where the data is kept confidential and is part of the state system. Can we do that?
Okay, I've got like 5 or 6 things I'm going to punt to the work plan session of our agenda today as a result of this conversation. So Ashley, again, I want to thank you for sharing your story with us, and best to you and going forward in the future. Sarah, I thought I saw in the chat box at least one other patient.
Yeah, it looks like so. Veronica is indicated that she would like to give her patient testimony. However, Veronica, I've tried to message you. I do not see your hand raised. So I'm not able to call on you, but I do know, Chair, that there is also one patient testimony that came in. So I'm going to just turn it over to Leslie and Veronica. If you can hear us now, if you could please either connect with me, let me know what your phone number is, or take this time to raise your hand so we can put you into the meeting after Leslie reads in some testimony. Thanks so much.
Okay, this testimony is from Michael Peretta, who is a cook at HMS Host at McCarran Airport. He's been there for 34 years, and he's a culinary union member for 35 years. My name is Michael Peretta, and I'm a patient at the Culinary Health Center. I've been using telemedicine to communicate with my doctor since coronavirus hit Las Vegas. Telemedicine is great because I'm able to talk to my own physician. She is really good at what she does, and I've been under her care for years. Just the other day, I had some aches and pains, and I told her about it. She gave me some medicine, which I get to pick up quickly, and more phone numbers for further testing. Another time, I ran out of medication for my asthma and called it in for an appointment and received refills right away. Using telemedicine is better than not seeing a doctor, and it's better than not seeing a doctor who is not familiar with you and having to start all over again with a new person. With telemedicine, you talk to your own doctor who has your records and charts. To make an appointment, I send an email or call the Culinary Health Center, and my doctor calls me back and we talk about what's going on. Right now, I'm even figuring out how to get back to work with asthma through telemedicine. My doctor has been able to get medical notes to my employer, and we've been trying to work together to figure out the amount of breaks I will need and how long I can work. All of this is done over the phone through email and fax. I look forward to when Culinary Health Center reopens, especially because the Culinary Health Center has free primary care visits and a free pharmacy. I think it would be a good thing to have telemedicine around, especially if you don't need to physically see your doctor to get your prescription filled. It eases up the lines down at the clinic and makes it easier on patients if we can just call in. We can get our prescriptions refilled, get a diagnosis, and get referrals for testing like I did this week. Nevada should definitely make telemedicine available for more people, especially because there are high-risk individuals who need to stay home during coronavirus. The state should also make sure that patient information is private. I like that my healthcare information stays with my Culinary Health Fund. Everyone should not have access to my health records, and I should not have to opt out of each sharing. And I should not have to opt out of sharing, sorry. Whoever's going to use or access my personal health data should have to ask me each time if I'm okay with that. And that's the end.
Thank you.
Thanks so much, Leslie. It looks like there's some technical difficulties. I've been told that Veronica is on the line. However, I am not able to allow her to join because I don't see her on our end.
Well, I'd like to propose that we do have a second public comment in this meeting. And so if she can endure, let her know and invite her back if
yeah, I don't want to miss the opportunity to have her testimony at least be read into the record. So Leslie, if you could, I think Veronica's also done, she submitted a written testimony. So let's have Leslie read that into the record. And then if Veronica, if you're listening, if you do have additional comments, you can join us later on during the second public comment, and we'll try to work out the technical difficulties.
That'd be great.
here we go.
Okay. My name is Veronica Sanders Lee, and I have lived in Nevada since 2017. I recently went through a huge ordeal with my health. Excuse me. It is an excruciating story that starts with a doctor who could not be bothered to treat me with the care I deserved, and ends with me currently recovering from my 4th surgery for a problem that could have been solved with 1. On April 8th, 2019, I went to the Culinary Health Center with a pain in my pelvic area. They did a scan on my body and found masses on both of my ovaries and a hernia. I ended up at a gynecological oncologist who did a bilateral oophorectomy, after which I was diagnosed with ovarian cancer. During my oophorectomy, I was supposed to have a hernia fixed, but the doctor did not do that. She was also supposed to stage me for cancer on my uterus and biopsy other surrounding tissues, which did not happen. As a result, I did not have the hysterectomy. 6 weeks later, I had another surgery for the hysterectomy. After they proved to not care for me as a patient, I found a new doctor for a second opinion. The second oncologist told me that I needed to have surgery to properly stage me. For example, remove more lymph nodes, tissues from my pelvic, and repair my hernia. During the third surgery, they fixed scar tissue around my ureter, removed my appendix, and removed a mass in my pelvic region that, according to my second doctor, could be seen on the scan the 1 week after my second surgery. In April 2020, I found out from my PET scan that the second oncologist had not fixed my hernia either. The third oncologist who supervised my chemotherapy at the Comprehensive Cancer Center of Nevada referred me for a PET scan, and the hernia had increased in size. My third oncologist with the Comprehensive Cancer Center of Nevada referred me to my 4th gynecological oncologist to screen me for possible surgery to address the hernia. During my visit, they told me they would fix the hernia that was missed by the first and second oncologists. My 4th oncologist fixed my hernia just a few weeks ago. I am testifying today because I want to say that even though my predicament put me through pain, I would still like to offer my story for those trying to get cancer care through the COVID-19 pandemic. As you heard, I have had to go through many doctors to get the care team that I have now. I am a patient at Culinary Health Center and the Comprehensive Cancer Center of Nevada, and with them, I felt very supported and safe. Culinary is the top example. My experience with the Culinary Health Center through COVID-19 is that they always make sure that my appointments were lined up. If I leave a voice message, they tell me that somebody will get back to me within 24 hours, but it's always before that. They are very thorough. It's efficient if you are tech savvy. I love the idea of having this option if the city opens up after the pandemic is over, because my doctor's offices are far from where I live. I love that everything I do with telemedicine, which is private and protected. My appointments and communications are protected by a sign-in. With my doctors at the Culinary Health Center, I get a message that says, "You've got a protected text message from Culinary." It sends me a link to sign in, and it asks me questions that only I would know about myself. Once I answer correctly, the doctor's message to me opens up. I can read the question and respond. My oncologist has a similar system. We have a code. I'm the only one that knows that code, and nobody can sign in on my behalf. I'm able to do video appointments from home while I recover from surgery, and it is secure. I hope that more people can have access to telemedicine through state funding because it has really helped me this year. It's important to me to keep my information private. I'm against anyone selling my information. I gave that information to one doctor, so I think it should stay private. I don't think that anyone should have unauthorized access without my permission to my information, and they should not be able to sell it either. And that's the end.
Thank you, Leslie. Veronica, now it looks like you have joined us and you're able to unmute yourself. Do you have anything else to add to that testimony?
I just want to say thank you for giving me the opportunity to be a part of this meeting this morning. It is an honor to be able to share what I went through over the past year and what I continue to experience. And there are some good doctors out there who have really helped me through navigate these tough waters, and just an unfortunate experience that I've had to go through. And I do everything I can to keep a positive outlook and just know that hopefully eventually I'll be on the other side of this cancer diagnosis. So thank you for reading my story and giving me the opportunity to share my experience.
Thank you. Sarah, do we have any additional?
No, but this is the opportunity to ask Veronica any questions if she has any.
Okay.
Do any commissioners have any?
Yeah, I believe Bobette has a question. Bobette?
Thank you, Chair. Veronica, I just wanted to thank you for telling us your story. I thought the Patient Protection Commission was going to have an easier time getting patients to come and talk about their experiences. I thought public testimony would be, easier to get going. So I'm really relieved and happy when we hear from any of the patients. I think the conversation about privatizing data, keeping your data private, is an important one. And I think this conversation today about multiple doctors and bad outcomes is, I don't know how the Patient Protection Commission can start working on quality, and Sarah, I know we've got a really big list already of things that are a priority, but I hope that there's some sort of way to talk about quality inside the coalition that we haven't, inside the commission that we haven't yet, because I think these stories are really a testament to quality problems.
Mm-hmm. I agree.
And thank you.
Thank you.
All right, thank you again. Any other questions or comments? Sarah, do we have any more patient testimony?
That concludes patient testimony.
Okay.
Veronica, thanks so much.
Thank you.
Yep, thank you. Next on our agenda is approval of the July 6, 2020 minutes. Thank you, Leslie. Leslie does a great job on these every meeting. Want to acknowledge her work on the minutes. Hope the commissioners have had an opportunity to review them, and am looking for a motion to approve.
This is Tony Sloan. I move to approve the minutes.
Motion to approve from Tony. Do I have a second?
Second from Howard Barron.
Second from Howard. Any discussion? All in favor of approval, say aye.
Aye.
Any nays? No nays. Minutes are approved. Now I'd like to turn to a formal presentation that will be made by Jamie King. Jamie, welcome. You might still be muted.
Okay, great. So thank you so much for having me here, Sarah and Bobette. I'm gonna share my screen and pull up my slides. So today I'm gonna talk to you all about high healthcare prices and some things that Nevada can do to try and lower them through transparency, enforcement, and legislation. But first, I want to set the stage a little bit by having you all imagine, what if the price of food had increased like the price of healthcare? This was a study originally done by the Institute of Medicine back in 2013, and I have updated it to $2019. And so if the price of a dozen oranges had increased since 1945, the way that healthcare has, they would now cost $57. A dozen eggs would cost $65. And a gallon of milk would cost $160. And this is not organic grass-fed milk from Whole Foods, right? This is just a regular gallon of whole milk. And what this tells us is that there's something really wrong going on with prices in American healthcare. We also see this price differential when we look at the comparison between the United States and other countries. And what you can see is that we are an extreme outlier on prices, both in hospital admission services and also physician and outpatient services, kind of across the board. The exception of cataract surgery in New Zealand, which I don't know what's going on there, but they should check into that. What you can see is that we are an extreme outlier. And research over the last few decades tell us time and again that prices are the primary reason why the US spends more on healthcare than any other country. It's not because we use more, it's not because we get better quality, it's that we simply pay more for the same goods and services. And so the question is, what happened to healthcare prices? Well, three things happened. First, we failed to protect the essential elements of a free market system. We don't have great price transparency, and we failed to protect competition. We failed to rigorously enforce our antitrust laws. And when we failed to regulate to control prices when competition no longer existed. And so I'm going to talk about each of these in turn. So in terms of protecting price transparency, nearly 2/3 of American adults say that it is somewhat difficult or very difficult to find out what they're going to be asked to pay for their healthcare. And we heard this, from the patient testimony this morning. And you see this in a lot of the discussion around surprise billing. Patients simply don't know what they're going to be asked to pay. And oftentimes their providers don't know. Even worse, employers who are paying these bills and contracting with insurers, they often don't know what the prices are. We also see that states across the country are not doing a very good job of making sure that their healthcare price information is open and available to consumers, to employers, and to their government officials. Now let's turn and look a little bit at what happened with our antitrust enforcement over the last 2 decades. What you can see in this chart is that from about 1991 to 2011, that 20-year period, the FTC didn't win a single hospital merger case challenge. And so what that did, two things. One, it told the FTC to stop bringing these challenges. And two, it sent a message to the healthcare systems that they could merge without much fear of an antitrust challenge. And so what we saw was a large amount of merging within the healthcare system. We saw hospitals merging with other hospitals to form healthcare systems. We saw those systems then begin to acquire physician groups, laboratories, and clinics across the board through vertical mergers. And now we're starting to see cross-market mergers where health systems in one geographic area are acquiring independent hospitals in other geographic areas. And the data on this is very consistent, and it's very clear that these mergers lead to increased prices. This is especially so in the horizontal merger space. So post-merger hospital prices increase from 20 to 44% post-merger. We see reductions in quality following hospital mergers. We also see increased premiums in the ACA markets, reductions in wage growth for nurses and pharmacists, and higher costs. And this is really somewhat ironic, right? You would think that hospitals in larger systems would have lower operational costs because they can spread those costs out. But in fact, that's not what we're seeing in the way that they report their accounting. We're seeing higher costs in those larger systems than in smaller systems. We see the same thing happening when health systems acquire physician groups. So the acquired physician group, their prices on average go up by about 14% following the merger. And those increases are higher for cardiologists and orthopedists and other specialist groups. The results in prices are even more significant when clinics are acquired. So you see increases from around 32 to 47%. And also the hospital systems that are acquiring these entities also have their prices go up following the merger as well. So it's allowing both entities to increase their prices. Now, what I really want you to focus on here, and because it came up especially with the patients, is that we're not seeing quality improvements result from these vertical mergers. And why that's important is because it's often the reason and the justification given for allowing these vertical mergers to go forward. So they say, oh, this will help improve with efficiency. We'll see lower costs and we'll be able to pass that on. We don't see that. We see prices go up instead of coming down. And we see promises that the quality will be improved. And that has not borne itself out in the research. The other thing I want to point out about vertical mergers is that these are often unlikely to trigger federal antitrust review. And that's because the Hart-Scott-Rodino filing threshold is $90 million. And oftentimes, acquiring a clinic or a small physician group doesn't reach that threshold, which means that the FTC and DOJ do not get notice of these types of mergers. And if your state doesn't have a notification requirement, these mergers can fly underneath antitrust enforcement radar at the federal and state level almost altogether, allowing for stealth consolidation where we're just not realizing how much the market is consolidating across the board. Finally, with cross-market mergers, this is a new trend that we're seeing over the last decade or so. And we see that these mergers are associated with increased prices of around 7 to 17% in the independent hospitals that are being acquired. Now, what's interesting about this is that our antitrust theory would suggest that these price increases are impossible, that one entity in a market acquiring another entity in an entirely different market should not see an anti-competitive price increase. And yet they are popping up over and over again. And so what we're seeing is evidence of the fact that the way that we think about market dynamics in our healthcare system is not quite accurate, and that we need to be doing more to understand what's happening in our markets and what's driving up prices. The other thing I want to point out in this space is that hospitals that are rival hospitals of the one that's being acquired in that new geographic area, we're also seeing them increase their prices to shadow price the price increase from the one that's acquired. So it's having a bigger effect on the market than just the hospital that's actually being acquired. So this is something to definitely look out for in your hospital markets throughout Nevada. If you see an entity in Reno start to purchase hospitals or provider systems in Las Vegas and things like that, you want to pay attention to it. And so all of this consolidation has left us with highly or super concentrated markets throughout the country. In our metropolitan statistical areas, 95% of our hospital markets are highly or super concentrated. Nearly 80% of our specialist markets are. Almost 60% of our insurance markets are highly or super concentrated. And 41% of our primary care physicians. And I want you to pay attention to this number especially, because first of all, you can see how much it's gone up since 2010, over 113% increase in market consolidation. But why this is so important right now is because of COVID-19, a lot of our primary care physicians are struggling financially. They have seen massive downturns in their practices. People don't want to go into the doctor right now. They're canceling appointments, especially for things dealing with regular primary care. And so as a result, those physician practices have become very vulnerable to merger or acquisition by health systems. And that can lead to much more consolidation in this space. And they're likely to fly again under that antitrust radar, which means that we'll see prices go up for primary care. And that's really harmful and detrimental to patients across the board. Okay, so let's look, those are sort of the national numbers, but let's look at what's happening for primary care physicians in Nevada. So what you can see here is that close to 40%, as of 2018, close to 40% of your primary care physicians were already owned by hospitals or health systems. And that was pre-coronavirus. So you're going to see that number go up. It's just slightly below the national average. Your Las Vegas numbers are quite good, but also looking at 2016 to 2018, those trends are going upward. So it's definitely a place that you want to keep an eye on in terms of thinking about the impact to consolidation resulting from coronavirus. Now let's look at your inpatient markets throughout for all of your hospital markets. And what you can see here is in Las Vegas, your numbers are sort of just above that 2,500 mark, which is where we think of the market as being highly concentrated. And Reno is much higher, upwards of 46, 63 in 2017. And so that's in a much higher group. But these markets, Reno looks a lot like Salt Lake City and Las Vegas looks a lot like Phoenix. But these are, that orange band and DOJ mark a highly concentrated market. So you're well within those. And this concentration has a direct impact on prices, right? You see that your prices overall have increased 21% since 2013, but just between 2013 and 2017. And you're 10% above the national average. You also see that in Reno, you're about 3% above the national average. What's important on this slide is that you'll see that your utilization in Nevada is actually quite low. You're 27%, both in Reno and in Las Vegas, lower than the national average in terms of utilization, but you're paying more. You're paying 10% more in Nevada and Las Vegas and 3% more in Reno. And that makes sense, right? As your prices go up, people tend to use care less. And that's not something that you want. You want people to go to the doctor when they don't feel well. These are your inpatient prices. You can just see the trends are continuing upward there, and even more so in your outpatient prices. So those are going up quite substantially since 2013. Okay. I also just wanted to put in a figure on your emergency room prices so that you can see that they have nearly tripled on average in Las Vegas since 2008, and they have nearly doubled in Reno since 2008. And I would encourage you to look at private equity firms are acquiring a number of emergency room visits, and that might be a part of that. So you want to be paying attention to all the different entities that are acquiring your healthcare provider groups. So the question now is, what can be done about this? Well, there's a lot of places you can start, and I think the most important place to start is by getting your data. It's really hard to know what to target in your specific market if you do not have accurate data about what's happening in your space. Healthcare is very local, down to the individual market, and you need to be paying and targeting your legislative and regulatory impacts and efforts on what's happening in your personal markets. Second, you need to enhance antitrust enforcement. We need to do this across the United States, and I've got some suggestions for things that Nevada can do in that space that will help you improve that. And then finally, in places where the market is not working very well, you can pass legislation to support competition and address the market deficiencies. And I'll go through each of these. So in terms of getting your data, one of the best ways I think you can do this is through the creation of an all-payer claims database. This is from a website called the APCD Council, and you can see here that, as I'm sure all of you know, Nevada introduced SB 472 in 2019 to start one. It's my understanding that that bill did not pass kind of at the last minute, but this is a really good place to start, and it's something to keep continuing having a conversation about. I know that a lot of people think that all payer claims databases are really just focused for consumers, which they originally were, and it's a very important use of that data. But it's also the more impactful uses of all payer claims database information is for policy and enforcement. It can help state officials really understand what's happening in their healthcare markets as they function. It can inform merger analysis and review and let you know which ones should go through and should not. It can allow you to identify the drivers of cost and track prices following consolidation. You can also track utilization trends. So how well are you doing on COVID-19 testing? Are the prices that are being charged pretty much equivalent throughout the state? Are you seeing wide price variation like we're seeing in some places? You can really track what's happening in your state if you have access to this data. And it can help you inform your policy goals and then also follow those policy initiatives to see how well they're working over time. So it really gives you a lot of information. Now let's turn and look at your merger review authority. And how you can think about merger enforcement. So we at the Source on Healthcare Price and Competition tracked merger review authority in all 50 states, both for insurance mergers and for provider mergers. And in insurance mergers, Nevada is doing really pretty well. You have pretty strong, you have notice requirements, approval requirements, hazardous to the public interest approval standards. You've done a really nice job in this space. Where I think there's room for improvement is with provider mergers. You don't have a notice requirement or a standard of approval. And I think in this way, you could really start to track how consolidation is happening in your state. And we created kind of a rubric for how to do that. And so one of the things that I think is most important, the obvious place to start is with a notice requirement. And you can require any healthcare transaction that affects a broad scope of entities. So all providers, hospitals, physician groups, clinics, laboratories, any transaction that's affecting them should be required to provide notice. And you can decide whether you want that to go to the Attorney General or to the Department of Health and Human Services or some other state entity that should receive that information. And you want to receive that information for a broad scope of transactions, not just mergers or acquisitions, also affiliations. Those have become very powerful in terms of conveying market power. Really, any material change in ownership is the way you want to go so that you get notice of a broad. And then you can sort of decide what you want to do as a state with those different transactions as they come through, but at least you are aware of them. The other thing you can look at initially is creating a substantial review criteria and sort of asking the entity that receives that notice to look at the impact on competition, on affordability, on patient access, and the public interest. So I'm happy to talk more about this, but in the interest of time, I do want to sort of get through it, but we can talk about more parts of this if you'd like in the question and answer. And now this brings me to legislative options. So one thing you can do is with legislation is you can really target very specific market imperfections. So I know you guys have looked at surprise billing laws. That's the kind of specific market imperfection I'm talking about, or anti-competitive contract terms. So anti-steering prohibitions, most favored nation prohibitions. You can really put bans on anti-competitive contract terms or bans on surprise billing activities. We talked a lot about ways to improve market function, so I'm going to skip over that here. And then in the markets where you're just not seeing much movement and competition isn't spurring more competitive pricing, you can introduce regulation to have rate review and stronger forms of rate review. Rhode Island provides a really good example of this with their affordability standards. You can talk about rate caps for providers, and you can also think about introducing competition from the state via a public option. And I'm happy to discuss any and all of these topics. So in terms of takeaways, increasing consolidation has led to higher healthcare prices in Nevada. Increased transparency initiatives can help inform and improve the policy choices made there, as well as for consumers helping them make their own choices. Increased merger review and oversight can help limit further consolidation, and regulation and reform can help control prices when competition fails. So that's it, and I am happy to take your questions. Thank you.
Hi there. I know we will have questions, so thank you very much for that presentation. Babette, I see your hand.
Thank you. I have a couple of things. Thank you, Jamie. I think it's hard to know where to start on this, and we see your little sticker up there about University of Auckland, but I know you've spent most of your time
yes.
in the Hastings Consortium and the
Yes,
Hastings.
so it's
right?
very confusing why a professor from the University of New Zealand would be here talking to you. So I just switched jobs on July 1st to begin working at the University of Auckland, but my entire career has been spent at the University of California, Hastings College of the Law, where I was the faculty director of the UCSF UC Hastings Consortium on Law, Science, and Health Policy. And I co-founded the Source on Healthcare Price and Competition, which is a website that looks at price and competition in healthcare throughout the United States. I also started a master's program there on health policy and law. So all of my work has been US focused. My new employer requests that I let you know where I'm actually coming from now.
And what I wanted to say, I appreciate it. If it's okay, Dr. Packham, for me to continue. I think your work has been helpful in helping us figure out our work, but I think there's a couple of points here. One is we need to, at this point in time, we need to bring an expert from outside of Nevada in order to help us evaluate what's going on in the state. And I think that that is something that Nevada could really improve on. I've worked on transparency in healthcare in the legislature and in a lot of community committees for years, and it has been slow going. But I think we're making progress. I think the surprise bill legislation last session is sort of opens the door to figure out, you know, what else we could do to move transparency ball forward. And I'm really hoping the Patient Protection Commission takes this charge seriously. So I think I would like to add there has been private equity acquisitions in Nevada, certainly in Las Vegas. Culinary Health Fund has really experienced private equity taking team health, taking hospital contracts for ER docs, and then impacting rates for those services after the private equity comes in. I think the surprise bill legislation will help with that. I don't think that we know enough about the rest of the markets. And so I know in Nevada, I would like to add in Nevada, there is a provision in statute for corporate practice of medicine that should restrict doctors' practices being purchased by hospitals. But I don't know exactly the status of that. And there's been a lot of confusion with something that went to the AG for evaluation several years ago. So I think that's something that we could ask for some LCB clarification for as a specific issue as we move forward. But my big plea here with the Patient Protection Commission is we need more information, and we need some kind of group that's looking through that information and using that information and develop some expertise about how to monitor what's going on with the markets based on that information. So I think what Sarah put together in the work plan, and I know you're going to come back to that, Dr. Packham, is the 6th page is really about how do we create more transparency in the state and the ability to do that in healthcare across the markets with our high cost items. And then secondly, how does the PPC become an entity that would be able to monitor and oversee the use of this data, because developing reports and not having them used by anybody is one of the things Nevada has done in the past. It's not been great. So I feel like Jamie's given us a really good starting point here. I really appreciate the time, and that's what I'm going to be hoping we get support for in the work plan, is those two uses of BDRs. And it could also add, Dr. Packham, all your manpower BDR information, because I know that you've worked your whole career on manpower shortages. But if we know how many doctors we have, but we don't know where they are, and we don't know what's happened to those practices, and we don't know what's happened to the ownership of those practices and the governance of those practices, we're still in the dark in terms of how the market's moving. So I would hope we can reach consensus about more access to information.
Agree. I see some other questions. Before I do, I want to kind of just piggyback on what Bobette was saying. Jamie, in other states, what entities typically kind of have jurisdiction over the increased merger review and oversight functions that you mentioned on that last slide?
Yeah, so it varies state to state. Most states provide that information to the Attorney General, but in some other states, it would go to the Department of Human Services if it's a healthcare provider merger, or to the Department of Insurance if it's an insurance merger. That's generally where they go, to the extent that they divide. Some states, well, that's generally where they go if there's like a healthcare finance system, but oftentimes to the AG.
Okay, thank you.
Mm-hmm.
So I see a number of questions. Let's see. We'll do Teresa first. Go ahead.
Thank you, Chairman. Thank you, Jamie, for your presentation. Would it be possible to go back to the slide where you compare our costs in the United States to other industrialized nations?
Absolutely, yeah.
And I just want to put a comment out there that I appreciate the presentation and really comparing what's happening in Las Vegas and Reno, but I want to say that we have probably, I would be interested to know what's happening in rural Nevada, because Nevada is obviously more than Reno and Las Vegas. And I know that that data is probably hard to come by, but I think people in rural parts of the state have even higher barriers.
I think that's absolutely true. I didn't have much time to gather this, and so I had to use sort of what was available
Sure.
initially to me. But I think it's well worth, I think you're absolutely right. What we see in rural markets is that their prices are significantly higher for a whole host of reasons. And I think that, I've heard a lot of people say that in rural healthcare is actually kind of its own entity, and you need to treat it very differently than when you think about how to price things there. Pennsylvania has a really interesting rural health pricing model, and so there's different things you can do there. But yes, I think their prices are significantly higher.
Yeah, and their options are lower.
Yeah.
Outside of South Africa, I'm not sure what their model is, but it seems to me that the obvious distinction between us and the rest of these nations is that they have socialized medicine and they provide healthcare to everybody in their country. And I think that it seems to me that that is one of the biggest drivers of the cost disparities in this country is what we're charged as, to have insurance. And a lot of people don't go get care because they're told that they have to meet their deductible, which can be, just out of, if 40% of Americans don't have $400 saved, they're probably not going to spend that if that's their deductible. So I think that is something that I don't know that at a state level we can really accomplish it, but I am interested, and I'm wondering, Jamie, if you know anything about what's happening in Washington and some insurers providing a public option, and if that is something that Nevada could potentially tackle, because I do feel that insurance, private insurance, even what's on the exchange, you might be able to cover your monthly costs. Those other drivers, those things that keep you from your primary care or specialist could be barriers to access. And so I'm without grandstanding, I'm wondering if you can talk a little bit, if you know anything about what's happening in Washington.
So I do. I'm actually writing a paper right now on public options and all of the bills that have been put forth in the state houses in the last 10 years. Proposing public options, and we've looked very extensively at what Washington has done. And I think that for states, a public option is much more feasible than single payer for kind of a host of reasons. But it can be a way for states to target particular markets that are struggling, or it can be a way just to provide better competition in that space, so that in markets where you only have one insurer or two insurers, as they were facing in Colorado, I believe they had 22 markets that only had one insurer on the marketplace, in the exchanges. And so what they have done is require each insurer that's offering a plan on the exchange to then also offer the public option plan. And there's a wide range of options for states, and states can choose to be very heavily involved in setting premium rates, in requiring certain levels of coverage to be offered and certain amounts of choice. And states can just say, we require commercial carriers who offer insurance in this market to also offer a public option that caps. And the thing that sort of distinguishes public option plans from most other ones is that they seem to cap physician prices at some percentage of Medicare. That seems to be the thing that we see most often across the board. And the amount that they are capping it at ranges from just 100% of Medicare to upward, 160% in Washington. But I think those numbers can vary pretty significantly, but they're estimating that that's going to reduce their overall premiums by about 10 to 15%. And so that's pretty significant. And so I think that there's a lot that states can do without substantial investment of money or resources. I mean, it's obviously going to take some amount of effort and commitment, but states can sort of go all in, or they can take a more measured approach as they see fit.
Would you say, Jamie, it's more of a matter of political will?
I would say it's a function of the desire of the people in power to allow, to try and put forth a different option. I mean, I do think that we're attempting to provide competition in these, in this space, and I think they want to. But I think it's a function of figuring out how to do it, and hopefully, what we're writing is actually going to be a roadmap for that for states. Like, here are the range of options. Here's when you would need a Section 1332 waiver from the Department of Health and Human Services. Here's what you can do. Here's what other states can do. Here's the statutory language they used. So really trying to make it easy for states to go ahead and do that.
Please send us that paper as soon as it's done.
I will. We're working on it on a daily basis, but
Okay.
I will send it.
Okay, thank you. Dr. Khan, then Dr. Sloan.
So a couple of observations. One, there's a difference between obviously the merger and acquisition. For example, large corporations merge, and if one of they merge nationally, that makes a difference. Acquisitions could be local acquisitions. I mean, companies can come in and acquire, for example, a practice group of primary care physicians, or they can acquire practices of solo primary care physicians. I don't know how that gets regulated, if at all, between regulation and free market enterprise. So that's my question. Is there any example elsewhere how there has been some oversight of local acquisitions of? I'm more concerned about the primary care practices.
I'm sorry, you froze there for a second in the middle. Are you saying that I missed part of your question? I apologize.
So the question is, in terms of acquisitions of primary care practices, as you alluded to, that the primary care physicians just cannot manage their practices fiscally. It's becoming a burden. So they become a prime target for acquisition. And then how does one, if at all, regulate that? I don't see how practically it is doable.
So that's the reason to have a really broad, I share your concern, and I think that's one of the biggest areas of concern here, because these kind of purchasing of physician practices can so easily fly underneath state antitrust radar, and they definitely fly underneath federal. And so as a result, happening without much. The way to do that is to have a very broad notice requirement, so that the state, it's not going to challenge each one of these acquisitions, but it can over time monitor the action of any particular health system that appears to be systematically acquiring a lot of market power in the primary care physician space. And so over time, if you can see, oh, this health system has purchased 1, 2, 3, now 10 primary care practices, that's when you might start to bring a challenge, or that's when you might start to want to institute a consent decree on the purchase. And so you can do that through having a notice and an approval requirement.
Which is fine, but on an approval requirement, what is the basis by the state to challenge that request?
That it's anti-competitive. So I mean, first of all, you can ask your legislature to grant the Attorney General the right to approve it. That's what we're recommending in California, and it's coming forward in SB 977, which is moving pretty rapidly through our state legislature. So you can pass that in legislation and give the AG or the Department of Health and Human Services the right to sort of approve. And at different levels, you can sort of say, if you haven't heard from us, like in a low-level merger, like a physician acquisition, if you tell us and then 30 days pass and no challenge has been brought, or no notice that we want to look into this further has been told, then that's tacit approval, so that the AG doesn't have to go through and formally approve each of these things. But you'd want them to formally approve a bigger one. So you can do it at sort of a tiered level. But the AG at least has notice and then the ability to challenge a merger. And they can challenge it on the grounds of either through legislation that grants them that right, or they can challenge it on the grounds that it is an anti-competitive transaction on the basis of federal antitrust laws. And I haven't looked specifically to see what Nevada's state antitrust laws are, but most of them mirror the federal antitrust laws. But state attorneys generals can challenge any transaction on the basis that it would be anti-competitive on the grounds of any federal antitrust laws.
Thank you.
Yep.
Are there other questions? Tony, go ahead.
Yes, Jamie, thank you so much. Great presentation, very dense, lots of material there to digest. I really appreciate the macro environmental context here, because I think that there are certainly 3 conclusions you've made about what that macro environment looks like, and hence the recommendations follow those conclusions. There's a whole bunch more stuff, though, around what leads to potentially other valuable conclusions that I don't know are covered. And I want to hit a couple of things that are particularly important.
Sure.
Because I know you advocated on the transparency law piece of this. I was fortunate enough in my career to work in Maryland under the commission. And I have to tell you, it was not particularly all that was cracked up to be. I was a chief medical officer there for many years, and some challenges arrived there. But let's stay at the macro level. Some of the other things in the context that I think are relevant to the conversation have to do with those states that are on the map.
Mm-hmm.
The A and B states actually turn out to have an average income that's somewhere in the $15,000 to $20,000 higher per person range.
Where are we looking?
Very, very wealthy states.
Mm-hmm.
I think the second thing is,
are you talking about, which map are you talking about? Just so I'm clear.
your 2020 report card, state
Oh, yes,
transparency,
okay.
that
Mm-hmm.
one, yeah. So when you look at the A and B states, these states have incomes per capita that range from $5,000 to $15,000 higher than Nevada's per capita income range. The second thing is that's important. The Medicare spending in Nevada, so public spending in general on Medicare, is actually the lowest of all of those A and B states. Medicaid spending is actually far lower and was just reduced another 8% as a result of COVID. So we're not even keeping pace in terms of some of the spending that's going on. And remember, I'm always remembering how spending and price relate to each other, obviously.
Mm-hmm.
The third thing that I think is highly relevant has to do with the issues around quality. For 4 of the states that are mentioned on the map, they are in the top 10 for quality nationwide. Nevada ranks in the bottom 5% on pretty much all quality measures. So in the conversation, while we proposed that there was an issue that people are limiting their access because of high prices, in fact, the reciprocal may actually be in play. People aren't accessing, and therefore there's multiple reasons for why they're not accessing.
Of course.
And I think that going down a path of conclusions where transparency will fix that, or antitrust will fix that, is a slippery slope. Finally, and I think importantly, only one out of all of those A and B states, all of them have a state income tax. All of them. Nevada doesn't. And so
New Hampshire doesn't.
New Hampshire does not.
Doesn't.
So when you take that into account, I've got concerns about Medicaid and Medicare, public spending in Nevada already low, and as you highlighted, utilization being low, quality being in the bottom 5% of the country, no state income tax, a rural challenges in the rural context, as was brought up already. I think we'd have to take a more macro perspective in order to understand the other dominant forces within the macro environmental context before we run down a path of saying that we should more officially regulate. I liked your idea about data, but I think we have to be really careful. This is a potential slippery slope. And I think finally I would leave on this
Okay,
point.
Can I just ask you a question?
Let me just finish my point, and I'll happy to have you jump in. Last point I would make is I certainly appreciate the feedback on the issues of hospital mergers and quality and cost, the value proposition. The AHA released a white paper, commissioned a white paper not long ago, September 2019, that was released. And so I think it's fair to point out there are equivocal, there's equivocal conclusions coming from the literature about what they are. And it's important that we assess the value and the rigor of the scientific methods that went into them.
So I agree with you entirely. And I think that's why the data that I presented to you today is not from any party with an interest in it, right? This is done by academic researchers with no stake in the game, as opposed to an industry policy brief that is very targeted in what it's trying to propose. In terms of the 2020 report card, this is not an assessment of anything other than the state laws that are in place to promote transparency. So it's not a reflection of the wealth of any of these states. I mean, certainly New Hampshire has, it may be a willingness of their willingness to invest in transparency as a result. And I hear you that there are many different things that a state can do. I just think it's hard to know what you should do unless you have really good data about what's happening in your state. But in terms of rural areas, I mean, certainly Maine and New Hampshire have extremely rural areas, and they have great challenges around cost related to that. You know, some of the wealthiest states in this nation aren't on this chart. You know, California's got a D, New York has got an F. I mean, there's lots of places that have much more money than New Hampshire and Maine and Rhode Island or Connecticut that are listed here. So I think what's important to recognize here is that this is not a chart assessing how well they're doing in terms of market competition or anything like that. It's just saying these states have committed to transparency for their consumers. And so I think that is a place where you can start to get good information and look for yourselves. I mean, I think it's really important to rely on, you know, academic researchers, but also if you've got a government task force that wants to look at your own data and see ask the questions that you want to ask and from experts that you feel comfortable with, that's where you're going to be able to dig in and see what problems you're really having in that are specific to Nevada. And that's what I meant about the importance of having your own data. I think there you can look really closely at what's happening in your markets. And that was the only thing to point out, is that as a nation, we haven't protected that right very well.
Yeah, and I think that's fair. I also am struck by I appreciate the map and what it is to represent and not represent, and it set up some conclusions by virtue of its inclusion in the presentation that led to very specific recommendations, and that's what I'm calling to bear here. That the mergers. I think that there's a whole context here that goes beyond the 3 recommendations you made that we should entertain. I'm particularly struck by to your point, we have a lot of data. Our dear chair of the Nevada Rural and Frontier Health Data Book in January 2019 highlights some of the discrepancies between urban and rural areas, and some of the places where, in fact, the rurals are doing better. And so I think bringing that together is not a one-size-fits-all solution. We have to be able to adapt to the context of care. Thank you.
Jessica.
Yeah, you know, I think that this is a great start to this conversation, but to Dr. Sloanim's point, it would be interesting to understand all these drivers of like healthcare pricing, such as the insurance piece. So I just Googled this, but Nevada has the 6th highest rate of uninsured in the nation. And, you know, so you have hospitals, and I think like the ACA did a big part in starting to provide a funding source for people to get care. But it just would be interesting to look at pieces like that as well. And then I had a question on, you were talking about the mergers and all that stuff. Insurers are starting to create, like buy their own clinics and provide insurance. Do you have any information on, how that affects costs, or is that a good model, bad, or whatnot?
I think it's really all in the execution. So we know that some integrated systems are very successful at keeping prices low. I mean, you see Kaiser Healthcare has done a decent job of that. I would say that like it has started shadow pricing other entities in Northern California, and its prices have started to go up. But overall, I think what you want to be concerned about is consolidation in all of the markets. Because when there is not choice, when there is not competition, people have to pay what's there. Employers have to pay what's there, the state has to pay who's there, and that makes it really challenging. So to the extent that an insurance company purchases a provider group and tries to offer care through that, the question is what options are left and who is being excluded from that market. If those providers then are not allowed to contract with other insurance companies in that market, you then create a situation where, if like through exclusive contracting, and it's a very limited market, you then create the opportunity for that insurance company to really drive up costs, right? Because they might be the only game in town, because they have basically excluded other insurers from satisfying their network adequacy laws. So you need to look, but that's all, the devil is all in the details, right? Do they have an exclusive dealing contract? What is a part of that deal? So I'm not saying that that kind of integration is always going to be bad. It's going to depend on the dynamics of the market in which it's going into. And I think having a really good oversight of how those deals are happening, what the terms of the contracts are, and what the market that they're in is like, can do that. Pennsylvania has had a really hard time with some of its insurance companies purchasing provider groups and exclusive dealing, and that has created all kinds of problems in their Pittsburgh market with UPMC. And so if you wanted some examples, you could look to them as to what they've been trying to do to avoid that.
So maybe payer source matters a little bit, but you're saying the more important driver is the competition and just making sure that there's transparent competition in the market.
Yeah, I mean, I think just making sure that competition can continue to occur and that you're not excluding other insurance competitors from the market. I think payer source, yeah, because an insurance company has to compete. And so as long as they can continue to do that. I didn't get a chance to look up whether Nevada has a most favored nation clause, but that would also, a clause prohibition, but that would also be relevant to the extent that the insurer has the market power, political clout to make sure that providers don't give a better price to any other insurer in the market. So there's ways for insurers to prohibit provider organizations from making a better deal with another insurer. And that has led to price increases kind of across the board, because insurers, as it turns out, they don't have to negotiate a low rate for you. All they have to do is make sure that they get the best rate of their competitors. And if they get the best rate of their competitors, then they can pass through those rate increases to employers and consumers as a result in their premiums, and they stay the most competitive plan in the market. And so what you really have to be looking for is, what is the insurer's relationship vis-a-vis other insurers in that space? And it keeps innovative insurance companies from coming in and taking market share from a dominant insurer. Does that make sense?
Yeah.
So I see lots of questions, and I hope I get this in right order. Flo, Teresa, Howard, then Tony. Flo.
Thank you so much. Jamie, great presentation, and I will say a lot of material that we had to read over the weekend, so thank you for that.
Sorry about that.
No, it was good, and it was a lot, but it was really helpful. One of the things that I was really looking at was the all payers claim database information that you provided, and you really highlight Maine as one of the success stories, I guess, in terms of that information and the data collection. Can you tell me a little bit more about what makes Maine so successful, but also how does that roll over to the consumer in terms of that information and how they can use that information to better understand the value of the care that they're getting, as well as what they're paying in terms of, particularly in the cost sharing arena?
Yeah, so Maine has done a really good job. And if you guys have questions, I actually know the woman who administers the Maine all payer claims database, and I'd be happy to put you in touch with her. She's incredibly nice and friendly and would love to tell you all about it. But they have basically they started out as very patient focused, and I think they've maintained that mission throughout the all payer claims database. And what they do is they have a website where a patient can type in, who their insurer is, what they're being recommended for in terms of treatment, and then looking at where they can go that would be in network and get information on what the negotiated rate is. So not just what the charge master rate is, not just the sort of retail sticker price, but what actually the negotiated rate is, and then what their cost sharing would be. And so it's been something that's really developed over time, and they have refined it and improved it over a number of years. But they have a very friendly patient website or consumer access website that you can go to, and people can go to it in advance and sort of type in, if I go with this insurer, what will my price be for this particular doctor if I get this surgery next year? If I go with this insurer, what will my price be? And so it allows people to make those choices in advance of purchasing their insurance, which I think is really important. A lot of people talk about, well, your insurer will offer you, a lot of insurers will give you your cost sharing amount once you're already a member, but that doesn't really help you when you're deciding which insurer to go with. And so being able to see that in a transparent way as you're deciding which insurer you want to choose, assuming that you have a choice, which is not always the case, but that gives the patient a lot more power to target their choice of insurance to the kinds of things and the providers that they know they're going to use.
And then so thank you, that's very helpful. And then one other question that I had, I think in one of your last slides, you say, obviously competition is the most important thing to ensure that there's a lot of options available for people. And the more competition you have, obviously that will drive down price. So one of the things that you had said was there's potentially legislative activity to support promoting competition. Mm-hmm. What are some of those things both in the marketplace that we can look to that would help promote competition in the marketplace?
Yeah, I think it's a great question. So one of the things, is the transparency piece. And so one of the greatest things that we've seen, one of the greatest impacts from the all payer claims database is that by making some of those prices public, we've seen journalists and other people, state legislators and other people make those prices public. And it's been what we've seen is that not that prices have shifted because people have, switched their doctors, but because the prices charged by outliers have been exposed to the public. And so you've seen those entities bring their prices down because attention has been brought to them. And so you've seen a lot of providers saying, oh my gosh, I'm actually a pretty big outlier here. And so I'm going to lower my rates to remain competitive because people can now decide this. And we saw there's a great case out of Exeter, New Hampshire. Exeter Hospital was an extreme outlier, and over time ended up bringing down its prices pretty significantly because the all payer claims database in New Hampshire was able to draw attention to that. In terms of competition, just protecting competition through really rigorous merger review and paying attention and bringing challenges, or if you don't want your AG, I don't know the level of resources that your attorney general has, but if you don't want your AG to have to sort of consistently bring challenges, granting an approval process where for certain mergers of certain sizes or in certain levels of concentrated markets, just giving them the right to approve or reject the merger before it even happens, that can go a long way towards protecting competition. And then finally, I think the public option is a really good way for the state to offer an option to individuals. We've seen proposals mostly in the individual and small group markets, but also some states that are really looking at extending that out even to the larger employer market. But I think the place to start is definitely in the individual market. And that really allows you to inject some competition that has sort of the full power of the state regulatory authority in there to lower prices. And it doesn't in any way hinder groups that already exist, right? If there are insurance in those markets that are from private plans, they can still continue to be there and you can get all the benefits of that, but you can also put some pressure on them to lower their rates.
All right. Thank you.
Thank you.
Okay, I'm going to go Teresa, Howard, Tony, and then Bobette. Teresa.
Thank you. I kind of want to go back to what Dr. Slonin said about looking at this from a macro level. And I just want to say, I think one thing that drives up costs across the United States, probably in Nevada specifically, with such a high rate of uninsured, is that people don't seek out primary care.
Yeah.
And that leaves them, you know, potentially getting higher level tertiary care at a much higher cost. I think that the ACA very much tried to tackle this issue, but as we see death by 1,000, you know, it's slowly but surely things have been sort of piecemealed and pulled away, and I think that that continues to drive up costs. It really bothers me when we talk about things, healthcare, in terms of markets, because I feel like if we don't have a public option, if we don't have single payer, it forces us to look at it through the lens of profit, and that leaves a lot of people out. We already heard from a patient this morning who probably endured much pain and suffering than was needed because of these barriers in the market. And I guess I want to go back to this idea, if we were going to tackle anything, that the public option, if there's any way that our state can deal with that, I think that's the best thing forward. Because insurance is tied to your employment, I think we're seeing right now how significant that's going to be. Our state 15% unemployment rate now because of COVID. And so how many more people now are uninsured because of this? And if they could be automatically enrolled in Medicaid or be able to get a public option that is affordable to them, I think that would do a lot to improve outcomes for patients here in Nevada.
No, I think that's a really good point. And I think that, you know, that you're sort of hitting that double risk where primary care physicians are more likely to be acquired, which means their prices might go up and making primary care more expensive, and more people are losing their jobs and off of insurance. And so the importance of having a public option that's not tied to employment, I think is extremely, it's extremely important to have that right now. Some of the examples of public option plans that we've been looking at have strong emphasis on primary care and follow the ACA model of making it not have any cost sharing. And so that's something that can be done within that model. I mean, you can pretty much set whatever, you know, requirements, whatever things you care about into the plan for the public option, and then ask commercial payers to bid on it, or just simply offer it yourself. And states are really split between whether they just want to set parameters of it and have a state, you know, have commercial entities provide that, or whether they want to just offer it themselves and not work with the commercial entities. And their states are really split on that. But I think it's a really important point. We do need to have options available to people.
Howard, then Tony, then Bobette.
Thanks, Jamie, for the presentation. I actually spent most of my afternoon yesterday reading your treatise on effects of cost and found it interesting. Couple of questions or comments. One is that one of the things that your, I think, 90-something page summary kind of left out, at least in you know, largely, was the effect of payer mix on and how that contributes to cost or pricing. I think in Nevada, I don't know that we're that unique, but we have a very, very high percentage of our citizens that are already enrolled in Medicaid. We have 3.5 million population, and we hit the over 700,000 mark in Medicaid enrollment. When you subtract the inability of hospitals, for example, to negotiate Medicaid rates and to negotiate with Medicare, you're dealing with less than, you know, essentially 30 to 35% of the remainder people that are covered with some type of a health plan. And then when you really look at third-party pay in our state, most of the larger hospitals are dealing with less than 20% of their contracts that they really have some negotiating room with. So not to defend hospital pricing as a practicing physician, but I think payer mix is an important contributor to cost and pricing. One of the things that's been talked about a little bit is as a public option, and as we all know, there was lots of movement about that during the last legislative session. Mike Sprinkle and his quote unquote sprinkle care bill in the assembly that sort of got dropped partway through the session last time. One of the weaknesses was, and again, we're trying to look out for patients' best interests. When you provide a public option that pays at or below what our state pays for Medicaid, you have to be careful that you might not have an adequate network that you can put together to provide that care. And so you have to be careful whenever you start to investigate a public option that you don't sell a bill of goods to consumers and then not have them access appropriate care. And I think the payers that sit on this commission probably speak to what it costs for them to pay for hospital and outpatient care for patients on a per capita basis. The third thing that I was going to mention was that the all payer claims database, I think, is an interesting and probably a much needed idea, but for various reasons was not highly supported in our last legislative session by either the hospitals or especially the payers last time. And I was wondering if you could, you talked a little bit about political will and things like that. I think that that's something that we would have to overcome in order to get an APCD set up in our state. And then lastly, I wanted to comment that I was always taught that quality is a fraction of outcome in the numerator and a cost on the denominator. And so while addressing cost as the denominator, that's great. And I think we need to do that as a commission, but we also need to address outcomes as a driver of quality. And I think that our healthcare system needs to incentivize the correct behavior, the desired behavior, which is to improve quality at a lower cost. And that's, the triple aim that was discussed with the ACA and so forth. So I think that there's a lot of room for movement in incentivizing the correct behavior. And going back to earlier discussions that we had today before your presentation, an example is sharing of information between specialists. We heard from Ashley earlier, patient who went and saw multiple specialists and had to be the go-between between them to try and make sure that her medical information got passed through. I think a tremendous amount of cost savings could occur if we incentivize people to use the equipment that they already have to communicate with each other and send records and send notes when the patient has consented to share that information with their other providers. It's one of the banes of my existence is all the time that my staff spends trying to call records from other specialists that my patients see in order for me to be able to comprehensively take care of their GI problem. I think that there's a lot of room for improvement in that, and a lot of cost savings that we could realize as a state by promoting that idea.
I think those are all fantastic points. I think the point about payer mix is really important, and that's why you really have to sort of get the data in your own state and recognize what's feasible and what's not. I have not seen any proposals that are suggesting that a public option would pay less than Medicaid rates. I do think that would be very difficult for payers. In fact, most of them I have seen pay a percentage above Medicare rates, and I think that's something that should be done in consultation with the providers in that space. I think that's really important. And all of those legislative bills say this has to be done in a way that allows to get the appropriate, network in place and the appropriate market in place. And so I think that you're going to have to be able to build a market. You're going to have to work with providers to find out where prices can come down. And you need to really look at what providers are outliers in terms of price. You will find great price variation throughout this country in terms of different providers in different markets charging very high amounts. And so a lot of this can be bringing those outliers down and then everybody else coming up. And some providers will even come up on that. The other thing is if you have a successful and large enough public option, you have the opportunity to increase rates with Medicaid and sort of smooth that function as well to give. I mean, if you want to be creative about it, there's a lot of different ways that you can pay providers. And I am not someone who is against paying providers what they owe. They are actually the people that are out there saving human lives and they should be paid. My issue comes up, and they should be paid well. And my issue comes up much more when you have large health systems that have massive and billions of dollars in reserve, as what we're seeing, that they are then keeping that money and driving down payments to providers and holding the money kind of up. And so I think there's a lot of movement there where you can continue to pay providers well through a public option. But I have not heard any that suggest lower than Medicaid rates. That I don't think that would be successful in any legislature. In terms of the all payer claims database, I'm not surprised that they're not supported by hospitals and insurers. This has been sort of a consistent refrain. I think that they have taken consistent efforts over time to shield negotiated rates from public view. And I think that it's precisely because entities with large amounts of market power, first of all, market power often translates into political power. And so they have been able to generate super competitive rates, and they're not really that eager for people to recognize that. And so I think that they've taken large steps. You can see what's happening at the federal level on this as well. So you're going to hit pushback. And I think the way to do that is just to keep coming back to the points that I think Teresa made really well about the importance of, access to healthcare for all people and all residents in the state of Nevada, the importance of getting care in the time of COVID. The last thing you want is somebody to wait until they're really sick to go get a test, right? And they have to go into the emergency room or they have to go into the hospital. So I think this is a very opportune time to really push on trying to get those prices out in the public and trying to have people have better information and better access to care overall. In terms of quality, I totally agree. There is a point where you push price down so much that you lose quality of care, and nobody wants us to get there, right? And what we have seen, though, is that quality has not changed as a result. It is not improved as a result of these mergers. If anything, lower levels, and economic theory tells you this as well as the data, right? That the less competition you have, the more quality goes down. And we've seen that in our hospital markets. And so what you want to do is exactly what you said. You want to promote competition and you want to incentivize financially those entities that have good quality, that provide good quality care. And you can do that through, tiered networks in your system. There's a whole host of ways you can do that. Payment for value, payment for performance, those things, can be implemented within a public option. But part of it is that we see, and I don't know how much of this is happening in Nevada, but we also see as part of their contracts, providers with market power preventing that kind of tiering, preventing that kind of signaling of which provider organizations actually have higher quality and higher value. And so they're doing it via contract. And so I think quality is very important. And I think the EMR sharing is also, really important. Getting that interoperability up will be very important. So thank you. All great points.
Thank you. Next up, Tony, I believe you had a question.
Yeah, thank you, John. Again, appreciate the conversation that we're having. The dialogue is great. I want to say first and foremost, I am pro-competitive. I believe in competition and a market economy and driving the conversation. There are a couple of things, though, that I think are relevant, again, based on our state and our hospital markets that are really important to take account of. Just 3 years ago, Nevada was the only state in the nation with bare counties, where we had no provider network across many of our rural counties, and we were the last state in the nation to go through that. Let's not forget those challenges that we have as it relates to access. I think the real question I have here is, in the context, and this was, Teresa, I think you brought this up, in the context of the ACA, aren't there safe harbors that were developed to drive quality and reduce costs where we're all working together? Things like accountable care organizations, things like clinically integrated networks that incent people to work together as on the solutions and not just leave them on the side.
Yes, they were. Unfortunately, what happened with a lot of those initiatives was that organizations use the ACO safe harbors to merge and to acquire different entities and to be part of a same entity and to expand their consolidation or their concentration. And so what they did was, but then they never really did the hard work of integrating. And what we see is that when there is medical integration, clinical integration can drive down cost and be very successful. But just having a merged organization does not guarantee that clinical integration, nor do you need to have a merger or an acquisition in order to ensure that kind of clinical integration. And those two different ideas really got merged. And so because there was a safe harbor and because provider organizations were able to go in and basically say, we need to merge with this entity in order to create an ACO, courts were allowing that to go through. AGs weren't challenging it because it was a part of the Affordable Care Act. And I think it was never intended to be, I mean, if you look at the FTC and DOJ documents on that, they said that they were going to be very actively enforcing the antitrust laws, but I don't think that that got down to the individual AG and judges level. And what we have seen over time is that we haven't seen ACOs create the kind of clinical integration that was hoped for.
Yep. I think that a really important point. Thank you for that. I think, right, fixing that conversation is important. It, working together, certainly for the value proposition, improving quality and reducing costs is certainly some place that we are all trying to get to. That's the point actually behind the commission. A couple of compromises, it seems, that we've got going on, particularly as a state that consistently, again, is in the bottom decile of quality. And we've seen, even particularly in this COVID pandemic, where the public health infrastructure needed to be supported by the private infrastructure. There was simply no data organization. There was no data streams that were available. There were no, there was insufficient testing capability. There was no contact tracing at the public health level. And so the private enterprise needed to step up in order to support. God help us if we didn't have hospitals and other organizations that could come to bear on creating the data, driving the testing, doing contact tracing, and supporting our state during COVID. We'd really be in a mess. And that gets to the next and most important point, probably I'd love for you to respond to. John, in his work, has highlighted the per capita workforce challenges in the state, which cross disciplines, but not the least of which is primary and specialty care. And we heard from our patient this morning about the lack of coordination around accessing specialty care. But the reality is you can't attract doctors to the state. That's the reality. And per 100,000 per capita, we are very far under what you expect to be delivering. And so that creates an access problem of its own. In addition, one of the only ways where you can, if you want to be creative and innovative to get doctors in the state, you could hope on a pipeline with the university system, but that takes years. So one only other way is to recruit to the state physicians who can serve up that access problem and provide the kinds of specialty and primary care that we need, or we could just let people continue to suffer with lack of access and die. And that's the reality of living in a rural state where there's disparity. Go back to where we were a couple of minutes ago. Having bare counties as the only state in the nation is a really hard place to be until somebody stepped up with creative mechanisms. So I want to be careful about framing a solution set that is kind of created in other settings and applying it in a context where the issues are highly variable and some of the challenges are not seen in other places. There's an N of 1 example in Nevada around Bexar counties.
No, I mean, I think that's a good point. My understanding is that Nevada no longer has Bexar counties, and that it's doing better in that front. And that's where a public option, I mean, a number of states have actively put forth public options to eliminate the problem of Bexar counties, and they've required those entities providing the public option to provide, multiple plans in those Bexar counties for about 5 years. And so that is one option and way of doing it. I think your point about workforce is incredibly important. And we have a physician shortage that is really extreme. And I imagine in places with large rural areas that is especially acute in those spaces. And so there are creative options there. We currently have, and you can, I don't know where you are in terms of your scope of practice laws, but there's a lot that can be done with broadening scope of practice laws in that space. There are also a very large number of physicians that have been graduated medical school, but have not yet entered a residency program. And there are a number of states that are looking at being able to give them, some kind of oversight. They're calling them assistant physicians, and they're allowing them to practice under physician oversight, much like a nurse practitioner, but allowing them to serve primary care functions. They have actually more training than nurse practitioners and physician's assistants in terms of medical school and hours in clinic and things like that. And so this might be an option by which Nevada can offer those individuals places to work in rural counties under physician oversight. The other thing I would suggest in that space is that, are you all familiar with Project Echo?
Yep.
Project Echo is something that has been really successful in rural counties in terms of partnering rural physicians who are seeing a wide range of cases and situations, and allowing them to partner with people who are the specialists in that particular area at larger academic medical centers and other places. And they've been very successful at getting top-notch quality care into rural areas by allowing these doctors to basically have repeated sort of clinical meetings with people in rural areas around the country. So these doctors share on, things like diabetes and other chronic care issues, acute heart conditions, and then they talk with the leading specialists in the country in an academic medical center and get advice on what to do. And so it's a way for rural physicians to not feel so isolated in their practices, and to get sort of access to cutting edge referrals, and to hear from other rural physicians about what's happening in around the country. And my understanding is that it's been incredibly successful, and that might be another place to look for support.
We do have a pretty robust ECHO program here in Nevada.
Great.
Yep. The other question I would have is, looking back to that Bexar County conversation that we suffered with a couple of years ago, do you know why it actually got solved?
Do I?
Yeah.
No.
The private infrastructure stepped up. And it was only able to be done because we had sufficient bandwidth in order to do that. And so I think that there are important contextual elements here that we continue to lose sight of as we're having our conversation. But I just want to make sure that that macro environment is so complicated. Driving costs down and quality up is so important to our value-based work together, while we preserve and assure access. I think are essential elements to our work. Thank you.
Thank you. Bobette, did you still have a question?
Yes, thank you. Thank you, Chairman Packman. Okay, Jamie, thank you. You're covering a lot of territory here. It's been really helpful. I want to go back to some of the things the other commissioners have said and weigh in a little bit. I really appreciate Phil Kahn talking about transparency and asking to see why it works and what makes it work and how to increase it. But frankly, the prescription drug industry is the industry we're having the most trouble developing transparency with. So if transparency creates a way to see outliers, and then the outliers are modified because of that scrutiny, that is exactly what the diabetes legislation and the asthma legislation that passed in Nevada for prescription drugs was supposed to do and has done. And having the when prices increase enough to generate scrutiny by the state, then that's supposed to be publicly reported. The problem in the prescription drug industry is then they fight the idea that transparency is a state right, and they actually take a position that prices are a trade secret and that information supplied to the state is a trade secret. I don't know the solution to that, but I'm really glad to see the pharmaceutical rep on the commission talking about the importance of transparency, and I hope that there'll be support there for figuring out a next step on transparency in the prescription drug industry. We'd really like to see more drugs added to the transparency program that we started for asthma and diabetes in the state, and Nevada should get really a lot of credit for creating those programs. They were one of the first states to do anything on transparency in prescription drugs. So kind of, you know, it's got to be industry-wide. Prescription drugs is our second highest cost in healthcare after hospitalizations. Secondly, I want to say something about tiered networks. Jamie, you talked about the importance of that tiered networks could play in modifying price, and tiered networks really mean, you know, members of the health plan would pay more to use one system than another system, and we've experimented with that in the Culinary Health Fund. I think in the state of Nevada, there's been a real effort by some of the nonprofit plans like ours to figure out how to maintain access and choice. But I think your point about contracts currently can be written in a way that prevents even being able to do that. That's a real thing in Southern Nevada. I don't know about Northern Nevada, but that is something that happens in the hospital industry in Southern Nevada. So I think it's one thing to have 13 hospitals in Southern Nevada, but people don't understand you're talking about 3 health systems. You know, 13 hospitals, but 3 health systems. And then we have one public nonprofit health system that that one of our commissioners is a CEO of. So I think that tiered network thing is something we should return to legislatively. The final thing about tiered counties that Dr. Slonim is raising, I don't see the relationship about Bexar counties having to be solved by the private sector. In fact, the first 2 years of the exchange, the co-op existed, and the co-op was asked by DOI to go into the rural areas and fill all 4 regions of the insurance market in the state so that there wouldn't be Bexar counties. So the fact that the co-op programs nationally failed and is a long story about the way it was created federally, and you couldn't fix some of the things that were happening federally at the state level. There was still that solution, and it worked. And a lot of people, the co-op ended up being the second highest, ended up being actually the highest enrollment on the exchange. In some sectors, we were at least 33% of the market. So I don't think the idea that there were Bexar counties means that that wouldn't have happened if there was a different structure. I think, and that I do think that the public option would help serve the purpose that the co-op served if it had the support and the structure needed to do a public option well. And I don't think that we should be thinking that it can't be a solution, because it really was. Thanks. So one more. So can we go back and just flag the idea that prescription drug transparency should probably be one of the things that we add to any prescription drug, any transparency discussion that we have in this commission?
Yeah, and I just want to tag that and just say that prescription drugs are something that you can make a part of your all payer claims database if you decide to go in that direction. But Nevada really is a leader in this space on prescription drug price transparency, and I think you definitely saw the impact that can be made in the diabetes market. And so I think that's really important. On the notion that healthcare and pharmacy prices are trade secrets, this is not something that has been affirmatively decided and proven in court. This is something that organizations will say, and oftentimes it's very effective when they say this is a trade secret and is protected by law. People will back off. But I can tell you that I have done extensive searching for those cases and they just don't exist. No one has equivocally decided that they can be and should be protected, like that negotiated drug prices or negotiated hospital prices constitute a trade secret. Moreover, even if one court did that, it's not universal. Trade secret claims are very fact specific and they often have a public interest layer to them. And so there are, this is not something that is open and shut. The only way that a state can make that open and shut is if they guarantee confidentiality and not to disclose those prices that are submitted to them as a part of the legislation. So I urge you in any legislation you pass to not agree not to disclose that pricing information, because then it will create an understanding that it's a trade secret and it can't be disclosed. But if you do not agree with that, the courts have not decided this. And you know, as we're seeing with President Trump's price transparency initiatives with hospitals, the courts are not agreeing that they cannot, that information doesn't have to be disclosed when the state demands it. So my colleague, Robin Feldman, who does an extensive amount of work in drug policy and especially drug pricing policy, has written a very compelling paper on why those prices should not constitute trade secrets. So don't be convinced by that argument.
Do you think, as a follow-up, do you think you could get that paper to us by your colleague? I think that would be helpful. And we have—
I sent it to you, didn't I?
Oh, I don't know. Okay, good. Maybe you could send it to Sarah so the whole commission can have it.
Yes, I will.
Good.
I will send 2 papers on that. Yeah.
Okay, I appreciate your comments. I think that's right. That's what our legal people have said as well.
Yeah.
Flo, I think Flo has a question, if not a comment in response.
Thank you so much, and I appreciate that, because I think it's important to note, and for the record, in terms of what pharma's position has been, pharma is not opposed to transparency. I think where we are concerned is certainly about the disclosure of trade secrets. And while we agree that not all things are deemed trade secrets, there are certain things that are. And so mostly what we have argued in terms of, as we look at from a policy discussion, is ensuring that the industry has an ability to argue before public disclosure occurs whether or not something is deemed a trade secret, because that is critical to our industry. So I just want to be clear, we did not, in California and other areas, we were not opposed to transparency. We actually sued in California based on release of information, pricing information, having that be released prior to a price increase. So it really was on advance notification is where we sued. It wasn't on the actual release of certain data. And you're right, to the extent that in contracts where we have contracts that have provisions in there that protect certain information, you are not allowed to disclose then that information, because that is a violation of the contract. Sure. And I believe, Jamie, in your paper, you talk a lot about that. And I think we have to be careful about the unintended consequences of public release of information prior to that information being known or disclosed to the public, because having that information and then it being released, particularly around pricing, can lead to disruptions within the market. And those can lead to price increases for consumers, and we want to be very careful about that. So while I appreciate that, I appreciate your concerns around transparency, particularly for consumers, we're fine with certain aspects of transparency, certainly, because that helps. But you can't just look at it in an isolated viewpoint either. Prescription drugs have benefits that overlap into other areas of the healthcare space. And so if you just look to consider all of the benefits that prescription drugs offer to alleviate cost pressures in other parts of the healthcare system. So you have to look at it as a whole. And I think that's why the all claims database provisions were not exempt from that. There is information in many of these other states that have prescription drug costs included within them. And so we're not saying don't include us in the all claims payer database provisions. We're just saying we need to do it in a way that ensures protection of confidentiality, of confidential information that won't lead to higher costs for consumers. We're happy to discuss those policies further, but I just want to make sure it's clear as to where pharma is in terms of their position.
Well, it would be helpful to see examples of when prices went up when information was made transparent. I don't know of that ever happening. And I know in Nevada, we claimed that in the state statute that that price is not a trade secret, and that the lawsuit in Nevada by pharma was not based on the scenario you just laid out, Flo. So I think transparency is something that pharma has really, really, I wouldn't say rejected, but I think slowed down. And I think if price is a trade secret, how are we ever going to get to understanding price?
Okay, I think Director Whitley has a comment on the all-payer claims database, and then Sean after Richard.
Sure, thanks. Really excited to hear the mention and then of the value of it related to transparency, but also specifically the state of Maine. That is the state we've been looking at related to all payers claim database. And you know, just to tie in the pharmaceutical price transparency piece, it was related to their use of the all payers claim database and integrating that pharmacy data in it. And you know, and in no way am I challenging any of the discussions, but just from a public servant perspective, the transparency piece is for me the driver for the consumers, and the value of that in informing on decision making. We've seen it with COVID-19 with our data dashboards for skilled nursing facilities and correctional facilities in terms of, you know, that real-time data update on what's happening really informs people beyond just, you know, a single stakeholder. And so one of the things with, it's interesting on the discussion of pharmacy is we had, I mean, before we even get to transparency, we had such non-compliance from several manufacturers that we did have the imposition of penalties. And one of our solutions that we built into the penalties we imposed was to be able to purchase the all payers claim database so that we could in fact make it easier to be compliant going forward. And so I will be going to the interim finance committee with a plan on you know, purchasing that. We have verbal from CMS that we still can fit under the 90% federal funding to 10% state match. And so it's a huge opportunity for us to take a big, I think, step forward in the space of transparency, which then informs us on our decision making. And, you know, that's the level at which I would comment in terms of this group is, you know, and maybe I'm just wore out from the special session that every stakeholder that has a lobbyist has, like, you know, a different data set to share with us on their perspective. And, you know, all of those need to be considered. But I do think there's some value to be had in the state being a neutral party, being able to host data that's shared with a primary purpose of helping consumers. So I'll keep advocating for that and we'll move forward. It would be great to see policy related to an all payers claim database. That's the bill that it didn't pass last session because it was introduced late and it really ran out of time. But it would be nice to see, you know, after standing it up to be able to see mandatory participation in it. So anyway, those are my updates on it, and we'd be happy to keep this body posted on as we move forward with acquiring a state all payer claims database. That's all I have.
Thank you. Sean?
Thank you, Mr. Chair. I have a couple questions, but on the all payer claims database, following up on Mr. Whitley, would participation be mandatory by all payers, self-funded, fully insured government, or is it just a fraction of them? And I ask simply because previously we spoke about how Nevada revised statutes only governs a fraction of that. So what other states done, Jamie?
So states started out making it mandatory for all payers. And what we have seen is that ERISA will prevent self-funded employers from having to from requiring them to submit their data. What you do see is that some self-funded employers are voluntarily submitting their data because they are finding that it's being submitted and put into a format that helps them determine, better ways to ask questions and how their data fits in with other data. And so you do have some self-funded employers that are willingly volunteering to do that. I do think that if we start to see hospitals being required to share their negotiated rates at the federal level, then that the federal government has said that they will share that with states that have all payer claims databases. So that will really significantly fill in some of those gaps. I also think that there is pretty significant movement at the federal level on this ERISA issue, whether it will be an amendment to ERISA requiring this information to be allowed to be disclosed to states, or whether it will be through a federal all payer claims database. There's been a lot of discussion of that at the federal level, but as of right now, ERISA prevents that.
Okay, thank you. And the information that's submitted, is it a provider's billed charges, negotiated rates, combination of both?
No, it's claims paid. So it is not billed charges. It is actual claims paid. So therefore you're not getting that billed charges inflation from it.
Okay. And then the last question is with respect to transparency, it's one thing to publish data. It's another thing to go get consumers to actually use it and have it find it to be digestible, which I think is very, very difficult in and of itself. But then after that, as consumers, patients, we generally go wherever our physician tells us to go for a certain service. We don't sit there and question him or her when we're in the room or when we get the phone call saying you're going here or there. Some people do, but a strong majority do not. So how do you go about changing that behavior to questioning the physician's choice of where to take you for a certain service because it's going to eventually perhaps cost you less by going out and utilizing some database or some transparency tool that's out there? I just find that to be very challenging, and I'm just curious how other states might.
I think you're exactly right. So first of all, I don't think there's anything to suggest that we want patients really challenging their doctors on where they're being referred to. And what you're saying about consumers oftentimes going where their provider refers them to, they may, is quite accurate. And we see that a lot with specialist physicians. Where we see people making movement is when they're deciding what laboratory. Their provider says, go have a test, and you can go to any Quest laboratory or any laboratory you want. And so you can pick, and that's where we're seeing some movement. Where do you go to get your MRI? And we call these shoppable services. And so we're seeing reductions in shoppable services. There are states that have very successful consumer-based web pages that allow them to see that information. As I talked about in Maine, patients are using it to pick which insurer they want to go to based on the negotiated rates between the insurer and their particular providers of choice. The bigger thing, the way if you want to change consumer behavior, the way to do that is to get that information into the hands of the provider so that the referral is actually made on the basis of price. So oftentimes physicians are like, oh, I could refer you to these 3 orthopedic specialists. I know them, I like them all. But in your plan, you'll pay this much to go to Dr. Smith, this much to go to Dr. Reynolds, and this much to go, to Dr. King, whatever. So at that point, if you can get that information integrated into the healthcare electronic medical records, which I know that United Health is doing in a number of its practices, that's where change can really be affected, because you have that doctor realizing, oh my gosh, I've been referring to Dr. Smith for years, but it turns out that he's actually charging patients a lot more. You could go to Dr. King, who is closer to your house and actually lower price. And so that's a real impetus of change where you make it at the referral. We do not want patients going against or challenging or their physicians or having a breakdown in their relationship with their provider. That is not the idea. The second point is that as the point I was sort of making earlier, which is that the real benefit, the real place where all payer claims databases are going to move the market in terms of price is not necessarily with consumers making those different choices. It will at the margins for sure, but the real benefit is in policy and where you can see as a state that problems are arising. Where is utilization where are you overutilizing services? Where are you overutilizing low value services? Where do you have massive price variation that shouldn't be there, that isn't reflected in quality? Where are you seeing prices being driven up just on the basis of market power? Where are you using, too many goods and services in this space and not? And that's the information that really can be provided to you through an all payer claims database. It allows the state legislature to stop shooting blind and being kind of persuaded by different interest groups and really use its own data to make good choices about where to target initiatives and regulation. And you can prioritize what's most important for Nevada, to Dr. Slonem's point, like what's happening in your specific market that needs to be addressed first, second, and third. That's where the value in the database is. It's not to say that it's not with consumers, but I take your point 100% that you're not going to see maximum movement in that space.
Thank you.
Thank you. Any additional questions? Teresa.
It's just a quick comment, just on the kind of public health side of all of this. Dr. Slonem made a comment about the private sector coming in and somewhat supplementing the public health, how public health had to address COVID. And I think that all those entities probably appreciate that, but public health has been starved in Nevada for years. It's going to be starved even more after the legislative session. We didn't, I guess, have the guts to raise taxes. So there's things that are going to affect the market regardless of all of these things. And, we fail across a multitude of indicators, one being mental health, education. We fall at the bottom of any bad or any good list and the top of any bad list. And that makes it hard to attract providers. If you say, come to our state, we have some of the worst education outcomes in the nation. So I think that all of this stuff is really good, but as long as we continue to starve education, public health, and other things that impact the social determinants of health, all of this is for naught, because we have to improve us across looking across multiple indicators. So I just wanted to kind of make that point. So I'll get off my grandstanding.
All right. Well, Jamie, if there's no further questions, I want to thank you. This has been a fantastic discussion that's going to inform our discussion of the work plan later today and the commission's work going forward. My iPhone tells me it's 6:24 in the morning tomorrow in New Zealand. So
in California, the border is closed.
Okay.
It's I am same time as you. Yeah.
Oh, okay, good.
Yeah.
Now I feel much less guilty about what time you have.
If I had been up since 3, this would I would have been much more tired looking eyes. Yeah.
Okay, very good. I also want to give you a heads up. I'm giving a lecture tomorrow to a group of undergraduates on healthcare costs and spending, and I'm going to borrow your slide on the gallon of milk, dozen of eggs, and the oranges. That's a great.
Go for it.
I'll give you full attribution, but I just want
to
share that with you. And again, thank you for everything you've presented today. This was great stuff. So
thank you. It's my pleasure.
Yeah. What I'd like to propose is it's 11:24 according to Microsoft. I'd like to take a 6-minute break and then reconvene. And we'll take up agenda item 6 at that point. All right. See everyone in 6.
Thank you.
Thank you. All right, I see Jessica and Teresa, Babette, Sean, Mason, Tony, Flo, Howard,
I'm here.
Dr. Khan. Lenny. Babette, Flo, Dr. Khan, and Yarlene, are you there?
I'm here.
All right. I believe
Babette's here.
All
Babette's
right.
here.
Excellent. Thank you. I believe we have enough commissioners present to proceed with the agenda. The next up on the agenda is discussion of the commission work plan and potential bill draft requests. This is a standing item that we put on the agenda. And Sarah, I don't know if you wanted to kick this off with the updated work plan document you sent to the group. I think it's safe to say we've probably added a few items to that at least. And again, this is our attempt to just try to keep not just the issues, but some of the policy recommendations we've heard from guest speakers and that we've discussed for the last couple of months on everyone's radar, kind of to try to memorialize that. So Sarah, I don't know if would it be possible you just kick that off? And I know you.
Sure, I'm happy to. So commissioners, really this is an opportunity for you all, to discuss your recommendations, policy recommendations, bill draft requests. I know since I think it was our first meeting we came back, it was a recommendation for this body to start to organize some of your thoughts collectively, but over the last several meetings, most of them have just been via general topic. And so now what we're doing is just having a further discussion and a narrower focus on some of this commission's priorities. So this is your opportunity to go ahead and have a deliberation amongst you all to discuss a narrower focus and where this commission would like to go. Don't know if there's a particular order, Chair, in which you want to start, but the intent of this is to start to have this commission have a more narrower focus. We do only have 3 more meetings on the books before we have to make a decision as to whether or not this commission utilizes your 3 allotted BDRs. So this is the opportunity to have a thoughtful deliberation amongst each other and a discussion on some of these recommendations.
So I think with that said, I'd like to just open it up for starters. So.
Well, if we can, for organizing purposes, I think just if you want to, commissioners, just start on the first page and you want to start talking about policy recommendations as it relates to telehealth or COVID-19 management containment, I would make a recommendation that perhaps while the conversation is fresh, that you start deliberating on the issues that were raised in the prior presentation and kind of further your deliberation on that and start to have a narrow focus and see if there is consensus amongst this group to proceed with some recommendations or focus areas around those topics.
So Sarah, this is Jessica, just to clarify. So if we're talking about the prior presentation, are we focusing on access and affordability of healthcare to start off?
Yeah, that would be my recommendation. So I think on page actually 7, you've got a recommendation for a bill draft request around access and affordability of healthcare. In addition to that, a discussion around an expanded authority of the Patient Protection Commission. That particular recommendation is really a set of recommendations to accomplish a number of goals to enhance patient healthcare experience and state outcomes. So if you look on that page, if you all want to take a moment to look at that and then make a deliberation or discussion around some of those recommendations. That would be my recommendation, because I do think it falls directly in line with the presentation that you all just heard from. But it's at the pleasure of this commission to proceed how you think is best.
I think I said, saw Tony, then Bobette.
Yeah, thank you, Mr. Chairman. I'm interested particularly given the last conversation we had around the continued struggles for access and affordability in our state, only made worse by the COVID pandemic, and some obviously important and tough decisions that need to be made in the budget cycle. I'm particularly worried about access, and I think this BDR hits one of them. Priority populations funded by Medicaid, and how going forward we're going to assure access to care when they are among the state's most vulnerable and are only made more vulnerable by perhaps cuts that are coming our way. So by virtue of that, I think patients with mental illness is important. Kids and pregnant moms are important, and are among our most vulnerable, our seniors. And I want to make sure that we have, I don't know that we have enough data, but we have to look into these vulnerable populations to assure that they're not further compromised as we move forward with the after COVID work that we all have upon us.
Mr. Chairman, if I can for a moment, because Tony Sotom brought up Medicaid. I know that we have Suzanne Bierman on the line, and I believe she has some information about, federal funding dollars that have made available around the CARES Act. So if you would indulge, we could have Suzanne speak to that, because I think it directly aligns with what Tony just brought up, if that is okay.
Absolutely.
Okay, Suzanne?
Great. Well, thank you, Sarah, and thanks for the opportunity. I did want to highlight for everyone that HHS does have a provider relief fund for Medicaid. It's open for applications until August 3rd. It's my understanding that up until this point, participation in this program has been pretty limited. 2 to 5% of eligible providers have applied for these funds. So it is somewhat limited. I think up to 2% of reported gross revenue from patient care, but I think right now every little bit helps, and just wanted to make sure that you all were aware that there is some relief from the federal government through the CARES Act that is specific to Medicaid and CHIP providers. And I did provide an FAQ document that has information on who can apply, the eligibility requirements, and kind of the process for applying from HRSA and federal HHS. So Sarah, thanks for the opportunity to highlight this program. I just wanted to make sure that everyone was aware that that program is available and those funds are being made available to Medicaid providers through the CARES Act.
Mason, I believe you had a question, and then Howard.
Yes, thanks, Dr. Packham and Commission. Kind of going back to page 7 of the work plan, and then comment about focusing on some of today's topics that were covered. Yeah, and I maybe going back to the HIE, is there a conversation, or what were the barriers of opting out versus opting in? Because I think that would be a pretty agreeable discussion, and perhaps a good one for us to tackle to get us started. Because I think when you talk to everyone, having more information, better access at our fingertips for providers definitely helps with better clinical diagnosis, but also expediting care, and then ultimately reducing overall cost and duplication of services. So that may be I don't want to say it's easy, but because you never know what may come up against us on this. But and I know the Health and Human Services for Medicaid participants, it's a requirement, so we're able to capture that information. But other insurers within the state, we kind of lose that. And again, I think that may be a good step in the right direction for one of our BDRs, but I'll throw it out there to everybody else. And Bobette's got a lot of history on it, so she may be able to educate us on opting in versus opting out.
Howard, then Jessica, then Bobette.
I guess I was was going to ask Suzanne if she's still on the line. My understanding about the relief funds for Medicaid and CHIP providers is that if you received any funds from the Medicare aspect of the relief part of the CARES Act, that you were not eligible to apply for the Medicaid relief. And that may be in part why why you're getting such a low rate of response, is that the Medicare relief part of the CARES Act came out sooner than the Medicaid did. And as a provider who 60% of our patients are Medicaid recipients in our state, I can tell you we would have preferred to apply through Medicaid, but it came out after the Medicare one. So we probably got far less relief because we hardly take care of any Medicare patients. But if Suzanne could comment on that, that'd be great.
Dr. Barron, you are correct. That is one of the requirements of this federal program, is that to be eligible, providers must have received no payment from the $50 billion general distribution to the Medicare providers. So you're absolutely correct in outlining that eligibility requirement. And you know, I do know that a lot of providers are probably in that position, but you know, thinking of some of our home and community-based services, other behavioral health providers, just wanted to make sure that everybody was aware of all the opportunities are out there, but do certainly understand that that's a limitation for many providers. So thanks for highlighting that.
Jessica.
Yeah, so just right in line with what Mason was saying, it seems like low-hanging fruit that's less controversial, at least to start, could be the HIE stuff. And it'd be really nice to get a presentation like we did today on an overview of like what's happening. It sounds like it's a tangled web. And Bobette was talking about WebIZ. You know, I'd like to understand how all that works together so that we could make some good policy recommendations moving forward on that.
Noted. Bobette, then Teresa.
Thank you. I think Jessica said a little bit of that for me. I think understanding the capacity that WebIZ has would be important before we make decisions about HIE. I also think the HIE history of it not being a state-based, state-managed program, that it is owned by the private sector, and every patient in Nevada by statute being dumped into it unless they figure out how to proactively opt out, is different than a state HIE that's managed by the state like WebIZ is. So I think that it's probably true that it's less controversial than some of the other things that we've talked about today, but it's very controversial for us. If it were something that the state managed, we would have a different opinion about it. And if it were something that we understood how the funding would move forward, I think we would have a different opinion about it. And I think if we understood who owned the data, but having a state statute change to have everybody's private health information put in a private database for them to use is something we're going to oppose.
Right. So just going, if I could respond to Bobette, that's what I want to understand is all the pros and cons. And I think everyone, if we could get a better understanding of, that.
I agree.
Yeah.
Exactly. And have those questions answered instead of we want to do what New York did, because we're not doing what New York did.
Okay. Teresa.
I guess I feel like we're kind of having parallel conversations here, and I'm a little confused about what we're trying to accomplish right now. And I also thought that our focus was supposed to shift kind of to COVID. And so the policy recommendations I put forth were surrounding COVID and not generally. I mean, I would be pushing for, you know, things that are a little bit more about pricing and public health. So I guess I just need a little clarity about what we're trying to accomplish here in the next, you know, hour or so.
I think that was a rhetorical question to the rest of the commission as well. Bobette?
I don't think it's a rhetorical question. I think that the memo that the governor sent that we then went through in our meeting, like when we started really having meetings again, it sounded like we wanted to not table the 3 work committees. We wanted to postpone them. And it sounded like we wanted to use the governor's letter as a format to make sure that we addressed the COVID-related issues in this commission. But I think it would help if we could get a specific explanation from Sarah or you about exactly what the governor's letter was supposed to do to the agenda, because I've gotten mixed messages about it, as well as Teresa. I don't think we need to be doing only COVID work, but I thought we were put with the charge of making sure issues were front and center. But I think clarity would be helpful.
Okay.
So, Mr. Chair, I can step in and I'd be happy to discuss that. And I think it's really important for this commission and to recognize that I think the governor's intent when he put the letter together, again, this was back in May, was really to highlight that this was, you know, an unprecedented crisis. And he wanted to make sure that he paused and recognized the need to leverage all resources to do what's best for Nevada patients. And he saw this commission as one of those components, as a resource to help with both short and long-term recovery. Now, the letter was broad in that he asked for this commission to refocus, but the intent was to make sure that the commission didn't proceed without recognizing the current crisis. However, nothing in that letter changed our statutory obligation to do a systematic review of healthcare. So our charge remained the same. It was just the governor taking an opportunity to highlight this unprecedented crisis and then, you know, recognizing the ability to leverage all resources to make the best decision for long-term recovery.
Jessica?
Yeah, and in my experience, you know, everyone was like, oh, COVID, and then you realize that it all comes back down to these long-standing issues that we're focusing on. So I guess that's how I saw it, is that we need to consider the lens of COVID, but really all of these issues are the things that are going to affect COVID now and in the future. Right,
and I would be remiss if I didn't recognize some of the other initiatives that the governor, you know, created amidst this crisis. And that was a medical advisory team. It was also a COVID task force and a COVID response director. All of these things were being brought together to address the immediate focus of this pandemic. And I believe the intent of pulling in this commission was really more on the long-term recovery. And he just would be remiss if he didn't take an opportunity to highlight this crisis and utilizing this commission for the long-term recovery. Yep.
So are we going to turn back to the work plan, or is there more discussion? Because I just wanted to add a couple things to the work plan.
Please do.
Okay, so with access and affordability, I thought we had a really good discussion around licensure, and I just want to make sure that we don't miss out on that. And then the other piece is, and I don't know where this fits, but maybe like other states to, you know, pull in more workforce. So Utah, for instance, they have a tax cut of $10,000 for the first 5 years of physicians coming into their state. I'm not saying that that's right for us, but you know, I just think it's important to understand, I think I've said this before, what other states are doing if we're talking about competition and workforce and how we're getting people here. So I don't know.
They must have a state income tax. Is that possible?
It's possible.
Okay. Makes it a little easier. Babette.
On that, on Jessica's comment about licensing, I missed some of the last meeting because my internet went down. And I don't know if we talked very much about Nevada's history in dental reciprocity. And Nevada was 48th in dental access in like 2003. And we worked on it in the legislature to create a reciprocity program where if you were licensed as a dentist in another state in these PACs, and you had 5 years of no problems, a track record of no problems, then you would be admitted into Nevada without having to go through the Nevada Dental Licensing Board. And that one change in statute to add reciprocity, I think we're now like 27th in the country. So I think reciprocity really works. Dr. Packham, you're the expert on this, but I would strongly urge us to do whatever we can to add reciprocity to all our shortage areas. And I think it's a bit controversial for the boards, but I think that we shouldn't let that get in the way.
Dr. Khan.
So to be clear, we are still discussing the proposition on access and affordability of healthcare.
Yes, and the work plan in general.
Right. So on the access and affordability of healthcare, I have a question. That item number 3 says hospital data must display payer-specific negotiated charges and etc. So my question is, the intent of this, how does it impact patient care, patient access, and quality of care and delivery of service for the patient? Or is this primarily for the payers' benefit so they can negotiate better rates looking at what the hospital or negotiating with somebody else? Because it's the hospitals today, then it'll be the physicians tomorrow. So what is the intent vis-a-vis specifically for the protection of the patient? Because that's our focus.
I presume this was patient focused. Others? Bobette?
I mean, to answer that question, Sarah, I'm not sure what that number 3 is either. That maybe...
I think it's a little confusing. Is the intent of this work plan is really it was created to allow you all to provide a bunch of recommendations in between each meeting, recognizing that we have a limited amount of meeting space, and for all of you to provide the work that's necessary to accomplish a robust set of recommendations. So none of this that is actually outlined in the work plan is concrete. This is really just an opportunity to kind of collect the thoughts independently. I work with each of you and I protect your information that you share with me to build this. And so it's really just meant to help you deliberate on it. And the opportunity is right now to discuss what that path forward is going to look like. So this is just a starting point, and it's just accomplishing a set of feedback that I have received either in the meetings or in between the meetings, and then it's a placeholder for you to have a deliberation. So if you want to scratch this and just have a conversation about what is the recommendation for a bill draft request and which focus should this commission start looking at, you can certainly do that. But if we want to take this and build upon it, and if it's easier, you can say, let's remove that line or let's add in other components. But I do think it's really important that this commission start putting together a more narrow focus, especially because we only have 2 more meetings on the record before you all will be anticipating a work session. So if you would like a presentation on WebIZ, my ask for this commission is that the recommendation in which you want to proceed for a potential BDR, and are we diving deep into that issue, or is it with the transparency measures? Is that a little bit clearer for everyone?
And I would add, Healthy Nevada's also offered to make a presentation. Dr. Khan and then Bobette.
So my personal view is, I believe that this particular line is not directly related to the patient's well-being and protection and access and health issues, et cetera, et cetera. So personally, I don't think this belongs in our deliberation from a patient protection perspective.
I mean,
if I'm a patient, what do I care? What's the negotiated rate between? Because I'm basically paying a premium to my insurance company or managed care organization, and they deliver the service. It doesn't make a difference to me in my premium, etc. If anything, it may give me lack of access to certain providers, hospitals, physicians, etc., if they've been excluded from the network of that organization. So that's my view on this particular line.
Right. So I just have a quick question for clarifying. Do you think that this is actually speaking to the all claims payer database? That's just what I was wondering.
I can tell you that this entire line, I think, is really just a set of recommendations to really enhance And the intent was to enhance the patient's healthcare experience and state outcomes by implementing transparency measures that kind of help understand data trends. And so when you're looking at some of those line items, or you're looking at some of these recommendations, if some of those components don't really hit that target focus, then we can take that off. But I would say this is something that if it has the appetite for this commission to move forward, and you all want to dive deep into improving patients' healthcare experience and state outcomes by these transparency measures, then I think that if there's consensus that this is what the focus should be on, then what we can do is start talking about what components are necessary to accomplish that goal.
Babette and Dr. Khan.
Thanks. Well, I just think that Jamie King did a really exceptional job today in outlining why transparency is important to the entire system, and price over time, and price does impact patients. It shows up either in their premium, it shows up in their bill if they're uninsured, and it shows up in access to when a plan can or cannot negotiate a contract. So, and our prices have escalated dramatically. So I think that issue of whether number 3 is related to an all claims payer database is probably a really good question. I would like to focus on 1 and 2. I think that those capture a lot of what was said today from Jamie King, that I think she does have specific expertise in this area. So I would really like the commission to proceed in figuring out the possibility of creating a BDR that would capture transparency agenda, and items 1 and 2 I think fit really well into what happened today. There might be more, but I think 1 and 2 kind of fit that bill. I don't have the same opinion about 3.
Agree. Dr. Khan, then Tony.
So it's a quick thing.
Mr. Chair, if I can for a moment, do you want to survey the commission if that is something that there's consensus for this group to proceed with? Because I do think that, and I'm sorry, Dr. Khan, I just want to make sure that we do have a focus and that we at least address what Commissioner Bond had just recommended.
But before we go there, I'm sorry to interrupt. Don't we need a process? Doesn't this need to be grounded in process? I don't know that we can randomly pick things off of a list without having a consensus building approach from the commission that allows us to get our work done together, not separately, but together. There are great tools out there that are really easy to go. We should not do this ad hoc. We should not do this in a bunch of one-offs. We should be thoughtful about what we put forward as a commission and ground it in standardized process. It's the only way we'll prevent ourselves as a commission from being pulled apart.
I'm confused. I'm confused about that comment. I'm not sure what the process would be, but I think we're in the process. I think this is the process. If there's another way to do it, I'm all ears.
Yeah, there are some really clear consensus building tools that are available that we have not engaged in as a commission. They're well adopted out throughout the industry and numbers of industries with how you get groups of people to come together on topics that are relevant. What we're doing here is, to the best we can tell, bringing up issues that we're passionate about, but not engaging in thoughtful process and deliberation that gets us to the top priorities. And without that, our work is in jeopardy, because all it does is tend to separate the commission and not build us in an integrated way. We have so many opportunities in Nevada to improve health and healthcare. I mean, we really should be thoughtful, not just in the one-offs, but in the more thoughtful theoretical approaches to moving forward.
I just want to say I totally support what Tony just said. And I would love to, like, maybe Dr. Sonam, you can send those tools to John and we can review those. But I agree, like, it would be great to have this be a little more thoughtful and intentional.
I need to interject here for a moment because, and this is why it's really important with this commission, and I'm going to focus again that we only have 3 more meetings on the record, that I think, Tony, you brought up a great point, and so did Commissioner Bond, and that this is the opportunity right now to have that thoughtful deliberation and to have that thought and to throw out suggestions as to how you build a consensus. And so absent participation, either outside of the meetings or thoughtful deliberations now, when will this occur? And so when you ask about when, we only have 3 more meetings on the record. So do you intend to add in additional meetings? Is it, the desire of this commission to meet more frequently, to dive deeper? Right now, the discussion at hand is what focus area does this commission want to proceed down? How are we going to build our next set of meetings with the goal of having put together recommendations for first bill draft requests and then a full set of recommendations for later this year. So this is what the conversation is about in this moment.
So Sarah, I think we're almost done with this meeting. And I'm just saying that we do have 3 more meetings, and I don't think that Dr. Sloanum's tools would probably take longer. It would just give us a framework to like make decisions on. Is it Matt? That's what I imagine he's kind of talking about. So I just think instead of thinking, oh, this is going to take 6 more meetings, just in the next meeting, how can we have this conversation in a way that's more thorough and intentional, maybe?
Sure.
Tony, is that what you were saying?
I've got those, and I think that Tony, I'd be happy to distribute those to the rest of the commissioners. I think it would be valuable, but we again need to strike that balance with remaining time and what that would commit us to. I blocked out all my Mondays, so I'm all ears, but mindful of the time as well. Dr. Khan.
So my view is that obviously commissioners may have views about various subjects, issues, passionate, not passionate, representing the constituencies that they were appointed for, to get the perspective, medical, managed care, et cetera, et cetera. So there is a purpose for that background to be present, to be on the commission. Having said that, so when something is of interest to any particular commissioner, it's passed on, I guess, to Sarah, and it's brought to this commission, like we are deliberating now. And we are deliberating. It's not an automatic thing that something is on the agenda. So that's it. We are trying to develop a consensus, narrowing things down gradually. So we are down to a narrower agenda, at least bill draft is a draft, requests, language, issues. So as we deliberate like 1, 2, 3 items, we are deliberating. If we don't like one item 1 or item 2, we get a consensus. And if there is no consensus, that item gets dropped. It's not that it's a done deal, in my opinion, behind the scenes. I really think it's being brought forward in a transparent manner. These are some of the issues raised. And here you are to deliberate, discuss it, decide what you want to do with these, eliminate them or keep them. So that's my view.
You're absolutely correct, Dr. Khan, and thank you for that. You said it more eloquently than I did, but that is exactly the intent of this agenda item in this meeting now, is to get some consensus building around a certain focus area for our next set of meetings and work.
And may I say something? So I agree with Dr. Khan and with Bovet, and I personally support Bovet's opinion on concentrating on the access and affordability of healthcare point 1 and 2. And if we're deliberating right now, I think that's one of the bill drafts that could be passed if everyone else agrees or the majority.
Okay. Tony, then Howard? Or...
Yeah, with all respect to Dr. Khan, I think that the concern I have in our process and in our conversation is the minutes will fail to capture the value and weight of the conversation and priorities. It will continue to be random, and we have to make sure that we bring thoughtful approach. Deliberation is valuable, and there are tools that we can do in a public forum online while we're engaged in deliberation that help to highlight this. If you just do a search on this, there's 15 tools that pop up that help groups like ours to drive consensus and not separation, because otherwise it becomes a debate that doesn't help to build our integrity.
Babette, then please.
I don't know what the online tools are. I mean, we could do some kind of SWOT analysis. Maybe that's one of them. Maybe that's what you're talking about. But I do believe I feel like we've had a very democratic process where everybody has the opportunity to provide information to Sarah. She's asked in 3 consecutive meetings for people's thoughts. Everything that I asked her for is here. So I'm assuming everything that everybody asked her for is here. And I understand that we want to make the best choices, Dr. Solomon. I get that. You don't want us to miss a better opportunity, or you don't want us to make a decision that isn't the best decision. But the only way to move forward is have everything here. And she's asked a lot of times. So
Yep.
What's not here?
I think, Babette, I don't even want to know if you hear the bias in what you just said. Everything I've asked for is there.
Yeah, but I said, so
presented.
I'm assuming that everything everybody else has asked for is also there, which is what I said next.
And I'd like to
don't know why there's
interject.
bias there.
Okay, so I would like to interject on that, and Bobette is absolutely right. There is no bias in this work plan. This bias doesn't exist, and anybody who has contributed in whatever form, it is on here. I've worked with each of you individually. I have reached out. I have made phone calls. I have sent emails. I have asked for your contributions over and over again in many different forms. And if you have provided contributions to me for this, it is there. There is not any contribution that is missing. And so what I believe Bobette was saying is that she has provided contributions, and she thought that this was the way in which we were going to have some deliberations, and I believe that was the intent. And in my memo, it's captured, the first ask of this commission from the first meeting, and all of the action since the following meetings when we agreed to start putting together this plan.
Guys, I want to remove the passion from the conversation. Bias isn't a negative thing. We all have lenses into the work that we represent as we come together. That's just natural. Our object is to manage that in the context of a commission so that we can move forward as an organized body with recommendations. That's the only point of having a conversation.
No, I appreciate that, Dr. Slonim, and I agree with you that it's not negative. And the only reason why I was responding was just for clarity purposes, that there was no omission of any contributions in this work plan. That if you provided contributions to me, that they are all captured in this work plan for deliberation by this entire commission, with the anticipation that we get some sort of consensus to move forward on a particular topic or narrower focus.
And what I was trying to say is, I don't know what else to do as a single commissioner here, because I feel like I followed our first charge, which we were trying to do subcommittees, and then our second charge to try to make sure we were responding to COVID, and now our third charge, which is get these BDRs ready. So what I'm trying to say, Dr. Slonim, is if I have bias, of course, we all have our own entities and issues, but I think it's unfair to use that statement and not acknowledge that everybody else is in the exact same situation, has the exact same access to do the exact same thing. And I think that it's been our responsibility for all of us to do it.
Teresa, then Jessica, then Dr. Khan. Teresa?
Thank you. I am biased. I'm biased for the patient. So this conversation is kind of like what patients go through every day, having to kind of navigate so many different stakeholders. And so it's a hard process. I agree, having facilitated groups and doing consensus building, there is some, I think there's some benefit in that activity. And my suggestion here is that maybe we've had a lot of presentations, we've had a lot of information provided to us. And I'm wondering if our next meeting can be solely, whether you want to call it deliberating, consensus building, whatever it is, building that buy-in that we all desperately, I think, need to maybe move this work forward. And then if we can narrow down what it is that we need to focus in on the short time period. I think a lot of this is out of our control. Nobody saw the pandemic rolling in the way it did and hit us. We're still really in that kind of forming phase of a group. And so it's hard for us all to kind of come together and gel and say, this is what we're going to do moving forward. So maybe if our next meeting is solely dedicated to this kind of activity of really deliberating what it is that we want to focus in on, and then we can identify what are the presentations that we would need to really formalize a BDR. That's just my suggestion, my 2 cents.
Right. So I agree. So Sarah, I think you've done such a good job. I just want to give you a lot of credit for working with all the commissioners and really raising the topics to where they are. And I don't think we have an overwhelming amount of topics. I thought we were making a lot of really good progress today in like the conversation that we had around transparency and also, you know, the HIE. I think Dr. Slonim is not saying to restart from the beginning. I think that it's like, hey, we have this now. We have these topics. As we move forward to really deliberate, there's ways we can do it in a smooth way, as opposed to saying, all right, commissioners, what do you think about number 3? And then one of us has, you know, more passion, says, I think we should keep number 3, or we should take number 3 off the list. There's just an easier way that would smooth us and protect the relationships we have on this commission. Because there are issues that we're going to look at where we're on 2 different sides. And so there's tools that we can like make that softer and try to find consensus. I think that's what Tony was saying.
Sure, and I just want to interject again. I appreciate your words about my work. I am really passionate about the work of this commission and really making sure that we help to do what we can to improve the lives of all patients in Nevada. And you know, with the tone of transparency, and what I want to say, I'm not sure what tools Dr. Slonim is mentioning or what's available, but you know, this is a public commission. We are subject to open meeting laws, and so we need to be mindful of our parameters in which we proceed, and we want that public engagement. We want to make sure we have to meet all the requirements of that. And you know, as we navigate this challenging task in kind of uncertain times, it really is important that this commission lead with transparency. These deliberations are intended and should be discussed openly and in front of the commission. And that was the intent of all of these public meetings. Now, with regards to the work plan, the reason why we have utilized that was to allow this commission's work to proceed in between the meetings. And so without your full participation and without each of your contributions, that work plan is only going to have limited items on there. And I do not have the majority of the commissioners who have weighed in. But that is a good tool, I believe. And this is something that we have started, in which if each one of you contributed to it, then you have the thoughtful deliberations at each meeting. But absent the contributions in between the meetings, so you can have it in front of you for full deliberation, you're going to get a product like you see in front of you now.
Okay, Dr. Khan, then Howard, then Tony.
So a couple of things. One, in my experience, having served on multiple state, federal task force, commissions, boards, et cetera, public entities, this has always been the process that I'm aware of. People on the commission, task force, et cetera, give their suggestions. I'd like this discussed. I like this discussed. This needs to be brought up. And then it's brought up to the whole commission, task force, board, et cetera. And then it's deliberated in the open. What cannot happen is behind the scenes, commissioners talking to each other and trying to quote unquote, deliberate in the background and then bring down so that everybody agrees in 5 minutes. So my personal thing is, in the interest of time, and not only today, but given the deadlines coming up for submitting the bill drafts, we need to somehow move forward so that we really move forward. Otherwise, we'll be here and not be ready for the August, et cetera, deadline. So I think we need to move forward. We have what we have right now, and we can look in the future if there is some more modification in the process that can be brought up. But for right now, if we get this agenda item moved on, at least with everybody's input, obviously, and then get some consensus. If the majority wants a certain item eliminated, it'll be eliminated. If the majority wants certain items kept, they'll be kept, and it'll be publicly deliberated. So that's my recommendation in the interest of time and the deadlines that we have been given by the governor.
Okay, Howard, then Tony.
I think a couple thoughts listening to all of this is one thing I think we can all agree on is that if it makes sense for patients and our citizens, then we should probably move it forward. So I think anything that is couched in that vein, whether it's an all-payer claims database bill, whether it be other types of ways to get transparency, whether it be to give the commission more power to monitor these things, whether it be to give the state attorney general more power to intervene in transactions that occur between institutions. If it can make sense that it's going to protect patients, and you know, I'm a provider representative, some of those things might not positively affect physicians or providers, but if it makes sense for patients, then that's something that this group should be able to concede and do. A question for Director Whitley is, if I understood you correctly, earlier you mentioned that that EHHS was going to move forward with an attempt to get a database, and I was just wondering if that takes the all-payer claims database idea off of our shoulders, or if you're moving forward with that, or are you moving forward with a piece of that? Can you elaborate?
Sure, thanks. This is Richard Whitley. It's the purchase of the all payers claim database. So it doesn't, I don't have a bill draft that I've requested. So if you look at other states that have them, there is a policy component to it. So I do think that still is an important piece of the all payers claim database.
Okay, so for example, if we were to propose a BDR that promoted the idea of creating an all-payer claims database for the state of Nevada, obviously the language that goes into the BDR and then the language that comes out of it is all negotiable after this group suggests something like that. You know, I looked at the items on the list that Sarah distributed, items 1, 2, and 3, and I agree 3 probably. I'm having a hard time translating that into a benefit for patients, but maybe 1 and 2 have some benefit to it. And if an all-payer claims database creation succeeds in moving forward, you know, each of those entities, whether it be pharma, whether it be payers, whether it be providers, whether it be hospital association, et cetera, all have to weigh in for the legislators to decide whether their piece is something that is important to include in there. But I think as a group, we could, if we're in favor of transparency, we could be in favor of something of that nature, even if the exact details of it still have to be fleshed out.
Chairman, if I can, for one moment, I just want to make sure that we kind of pause for a moment, because I think Dr. Barron, what you said was really important. And just for clarity purposes, if this commission decides that what is beneficial for the patients of Nevada is to pursue a bill draft request around patient healthcare experience with the end state outcomes, because I believe I've heard that, by implementing transparency measures that helps better understand data trends. If that is the focus of this commission, then I think what's important is that we make sure that we get consensus from the commissioners that this is where the commission would like to proceed. Now, the details, whether you're further deliberating on the items 1 and 2, all payer claims database, or other components of that, that is what should be discussed at the future meetings, right? It's then taking the focus from having that transparency bill draft and then going into the next meetings and then starting to deliberate on the components of that and how that'll look like. And so that is what I believe is the next natural step after this commission has consensus that that is the path in which you want to proceed.
So it seems to me, I'm sorry, Dr.
Go ahead, Barbara.
Thank you, Mr. Chair. It seems like we've heard a lot about transparency in today's presentation, and we do have recommendations for transparency under access and affordability of healthcare. And so I think we should consider trying to see if we've got enough consensus, if we've got a majority to move that issue forward. And so, you know, take a proposal to do that. And then if we don't, then we didn't get very far today. And we know that this is not, we're not at a consensus point. But if we do, then we could come back with the tools that Dr. Sonam's talking about to maybe vet what should go exactly in that language under 1 and 2. And then that's one bill draft, but we have 2 more bill drafts to go. So I'm kind of, I want to make sure we don't spend next meeting figuring out tools to reach consensus, and then the meeting after that bringing, you know, WebIZ. We're going to run out of time. I think we're going to run out of time. So we either need to schedule another meeting to add to that for the process, or we need to get this far today and then bring the tools into the next meeting for the detail.
So just for clarification on process, if you look at the agenda item, I don't think that we can have a vote on this today. It's only discussion. So we could identify it as a priority. And yeah, you're right, Bobette. I think potentially we should have more meetings. I mean, we're feeling scarcity of time and meetings. I'd be willing to do more meetings if that's what it takes. But I don't think today, like, I'm feeling a lot of pressure here, and there's actually no opportunity to take action. All we're doing is discussing the work plan and maybe adjusting, like Sarah has, of like, this is a potential BDR, which I don't think we can vote on.
I do believe you have the ability to put forth an actionable item as it relates to the work of this commission. So I would defer to our DAG for clarity purposes on whether or not you can take a formal motion to build a consensus around moving forward for a bill draft. It's not certainly not making a recommendation to do it. It's just a, and Bobette, I don't want to speak on your behalf, but it would just be a motion to start focusing on a potential BDR surrounding transparency measures to accomplish patient healthcare experience and state outcomes.
I would like to make that motion and see if the DAG approves.
I mean, I guess it is possible action.
Yeah.
Yeah, this is Deputy Attorney General David Gardner. Yeah, because it has for possible action, you could make a motion like that.
I second Bobette on the motion to discuss this access and affordability of healthcare more in depth on the next meeting.
I heard 2 different things there.
I heard multiple things, and I've got multiple people raising their hands. I guess I'd like to just take a step back and ask if there is a possible motion for an action.
I would like, Bobette Bond, Commissioner Bond would like to make a motion that the commission consider using one of our 3 BDRs to create a bill about expanding transparency in healthcare along with healthcare sectors, and we discuss the details of that in the next meeting, using whatever consensus building tools we can go through at that in time for that.
That sounds like a straightforward motion. Do I have a second?
I second Yarleni Roa Dugan for the record.
And I hesitate asking this, but is there any discussion? All in favor of that motion, say aye.
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 Any opposed?
Aye.
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 I'm not sure I got the opposed. Doctors? Who were the opposed?
Oh, I'm not opposed. I'm in support.
Okay. Wanted to make sure I got that for the record. Okay.
So what was the vote, Dr. Packham? I can't see everybody.
I had second.
Chair Packham, if it's easier, I think we can actually have Leslie do a roll call vote, just for clarity purposes, if that's easier. I didn't hear any opposition, but just for record keeping, maybe it is best that this commission take a roll call vote.
Can you restate the motion as well?
I'm going to have Bobette restate the motion, and then we'll take a
Oh,
roll.
wait, can I ask a quick question?
Yes,
I'm
Flo.
so sorry. I was on mute. I didn't realize. So as we're doing this, do we only have 3 BDRs?
Yes.
Yes.
Yeah.
Okay. And so with that, with all the things that we had on the table, from telehealth to network adequacy to licensure to now this, so what we're doing right now is we're committing, before we have all of the ones in front of us that we actually want to consider, we're gonna now vote to do this one and then limit our options for the next 2. Is that correct? I'm just trying to clarify.
I don't view this as finalizing a vote on a BDR. I view this as a deeper dive on an issue that we have consensus on with respect to transparency and possibly the all-payer claims database, unless I heard that wrong.
So it would really be helpful if we could really understand the process. Sorry to overuse the word, but I was under the same understanding, which was once we carry out this vote, this will be one of the 3 BDRs. This was not about further discussion. So ultimately, we're taking away, and I don't yet understand, to the point that Flo just made, with all the denominator issues we've discussed, we're taking one of our 3 BDRs for this issue. And I had a number of concerns about today's presentation, as you heard earlier in the meeting, and I'm not yet convinced there's not other priorities that rise above this one. That's my concern. But if this is just to have further conversation, I'm happy to have conversation.
Mr. Chair, our DAG would like to interject.
Sorry, this is Deputy Attorney General David Gardner. This motion is not binding in the sense that this commission can always vote a different direction. So even if you guys voted as this is one of your 3 BDRs, and then your next meeting you're like, yeah, we decided against it, and you vote to not make it one of your 3 BDRs, that would be perfectly fine. It doesn't bind you, so you have a lot of flexibility on what you can or cannot do. I just wanted to make that clear. So for this motion.
Very helpful, thank you.
And just, I would also like to interject too, because this is helpful for me and for my role to help be a resource to each of you and to this commission's work, because there is a lot of ways in which we can build the next agenda, hear from presentations. I think I have a list of like 20 requests from presenters that we want from this commission, but we have a short amount of time. So if I have a clearer understanding about the focus in which this commission would like to go, it helps set the meetings for the rest of our schedule.
Teresa.
Well, I'm just going to repeat what I said last time. I think that we've had a lot of presentations and we're not leaving enough time to have these really important conversations. So again, I'm wondering if we continue this very important part of our work and really not maybe have any presentations, at least for our next meeting, so that we can drill this down. Because I feel like I didn't even really know what I voted on. I'm supportive of transparency. I'm supportive of increasing access to healthcare for all patients, but I really don't know what I'm voting on. And I feel very unclear now of what our focus is. So I feel like we should spend our next meeting really figuring that out.
I agree. And I think, we've just spent, 3.5 hours here. We're all probably pretty burnt out and hungry to some extent. And then we're trying to have like these intensive conversations. So it would be nice to like have real discussion about this. And I also think that, kind of like what Dr. Slonim was saying, we actually have an entire work plan. So we just zeroed in on one item And then we went into those two topics on that one item, as opposed to coming back out and just looking at the whole thing. So, and the selection of BDRs, I'm not sure. I understand what you're saying, Sarah. It'd be nice to have that deep dive. I'm fine with that. If that could be worded in the action, if an action needs to occur.
Well, let me propose something in the interest of time. We could table this motion for today's meeting, and we could begin the next meeting, the meat of the meeting, once we get past public comment, approval of minutes, to start out with a discussion of the work plan, and let that be the bulk of our next meeting, and maybe defer any additional presentations up to this point. I like this discussion. It's a little maddening, but it's because we care about these issues. So,
but I like that approach, Chair Packham. Thank you for the suggestion. I also believe that to the point that so many people have made, our intent is to represent the people of Nevada here. And there are ways, even using some of these tools, and I highly recommend that we take a look at these offline, to engage the public in the decision-making process as we're going forward within the context of the meeting and open meeting law. There are well-established tools to do that work. And I appreciate Dr. Khan's historic perspective here, but just like evidence-based medicine evolves, so too does the work of our councils and our bodies to make better decisions as we move forward.
I'd really appreciate that, Dr. Sloan, for you to highlight a transparent process in which this commission does deliberation. And I would also would be remiss if I didn't say that having a motion on the record at this meeting that notifies the public that the intent of our next meeting will be to do a deeper deliberation on enhancing patients' healthcare experience on state outcomes by implementing transparency measures. And yes, that is not something that is concrete or part of a BDR, but at least having a motion to let the public know that the intent of this body would be to focus on moving forward with a potential BDR for that is helpful. Outside of that, we will build an agenda and make the best decision forward for what's most efficient for this commission. But the public is not aware of that. That is not something that the public then sees. But having a motion on the record today really does provide that transparent process for those of everybody who's watching now to know that that will be on our next meeting.
And I would like to add that that was my understanding too of the motion. We're not choosing a BDR right now. We're choosing to pick this one topic to move it forward so we can further discuss in the next meeting more in depth. So we're narrowing down our options. I believe that's what the motion was.
Dr. Khan.
So I would suggest, if there's no opposition to that, based on what we just heard, we proceed with the motion. It's non-binding anyway. It gives the public an opportunity to be present next time, since they would know that this is going to be on the agenda, give their input, and then move forward from there. So I agree with you, Mr. Chairperson, that we should proceed. That's my view, to go for the vote on this motion. Call the question.
Okay.
So, Chair, would you like Leslie to do a roll call vote on the motion?
I would like to maybe have Bobette repeat the motion.
I'd like it, if you don't mind, Mr. Chair, I'd like to have Leslie repeat the motion so that, because I was piecing it together from what Sarah was saying.
I've got lots of notes here.
No problem. And you know what, Leslie, I don't mind repeating the motion if that's easier for you, and if that's okay with the commission, I can certainly do that. Sure. I believe the motion is to move forward for the next meeting for this commission to focus on a discussion about a potential BDR that enhances patients' healthcare experience and state outcomes by implementing transparency measures that help understand data trends. So the focus of our next meeting will be on that topic.
That sounds good. So we have the motion. We've already had a second. Can we do a roll call or any discussion, I should say?
We just had discussion.
No discussion. Okay, good. Leslie, if you
Roll,
will.
roll call vote.
Yep.
Dr. Packham,
Yes, aye.
Dr. Barron,
Yes.
Teresa Bohannon,
My Zoom went out when everything was red, but I think I understand it, so I'm a yay.
Babette Bond,
Yay.
Jessica Flood,
Yay.
Flo Khan,
Yay.
Dr. Khan,
Yes.
Yarleni Roa Dugan,
Yes.
Sean Shaner,
Yes.
Sean Shaner, okay. Dr. Slonim,
Yes.
Mason Van Howling,
Yes.
okay, it's unanimous.
Okay, commission, be careful. We just reached consensus on something. So meant that in a sense of humor there.
Important.
That was the easy part.
Right.
That was the easy part. Yeah, it's now 12:40, and I'm wondering if we have any other comments or on this particular agenda item, because I do feel a need to keep us moving. Anything else on this for the good of the group?
Dr. Packham, I'm sorry, because I know we all are getting tired, but I am a little confused about, it's great that we're going to talk more about transparency and try to understand the pieces that could possibly go into BDR next time. I think that's great. But I'm confused about what we don't have on these agendas when people are saying that we need to get everything together on the work plan. I'm confused about why that hasn't happened yet and what's missing from the work plan and how we get that finished, because I don't think we have time to do a lot more.
Can I meet you halfway and say that leads into our next agenda item, and that is the
Right, that'd be
discussion,
perfect.
yeah, of what we want on a future agenda. We are all committed to at least 3 meeting dates: August 3rd, August 17th, and August 31st. And so maybe allow that to lead into what we want our next agenda. And I hesitate to offer that up, but whether we need more meetings. Howard.
Sorry.
You cut out. I didn't hear what you said that you were offering up. I'm sorry.
Howard?
No, I was muted. Sorry. I was going to suggest that we, to complete the discussion about the health insurance exchange, that maybe we do go ahead and invite Dr. Reeves to come and give a presentation about it and sort of the ins and outs, and you know, and then we can make an informed decision about whether that's something we want to move forward with or not.
Well, I think
that I'm sure I'm going to say the same thing as you, Babette, is that it would also be great to have a neutral presentation on like the larger perspective, not just from the HIE. So I don't know who could do that, but
well,
maybe
I can help. I can try to find somebody. I understand, Dr. Barron, I think you meant health information exchange, not health insurance exchange.
Absolutely. Sorry for misstating that. Yeah.
No problem. And Richard Whitley, can we put you on the spot to have DHHS try to bring up the record of the HIE in Nevada and nationally? Could we get some help with the research of what's happened nationally? So
Yes.
to Jessica's point, we have a broader picture.
Yes.
That would be helpful, because I've got files somewhere, but it would be good to have somebody who can find it.
Let me ask the group again, just for my clarification though, even if we do have an invited presentation or presentations at our next meeting, we're going to start off with the work plan though, correct? Yes or no? And I ask that because we typically take up the work plan discussion at a point of exhaustion. And I just wondered if we might want to flip the order. It's not a trivial thing, the order of things on an agenda.
I would vote that we don't have any presentations in our next meeting, and that we try to really dial down what it is that we want to focus in on. And once we have decided that, then we can move forward with presentations to inform on a more granular level the things that we want to include. That's just the way I see it, because like pointed out, we're all kind of exhausted. And then if we put a presentation at the end of an agenda, it just seems kind of unfair to that person.
So might I be as bold to suggest that maybe what we need is a topic for out of the work plan, because that's our guiding principle, out of the work plan that talks about health information exchange, not the specific HIE, but broadly exchanging information for the benefit of consumers that allows us to advance the coordination of care. That's a broader topic, but something we can certainly discuss as a component of a BZR.
So I think I missed the beginning of that. So yay on a presentation or not? I'm sorry, Tony.
Do we vote on that?
I think I missed part of what Tony was proposing. That's all.
No, I wasn't. I was not proposing a presentation. My point, Chair, was to suggest, just like we're going to have a conversation about keeping the work plan issues for conversation up front and personal. So I guess I'm advocating for no presentation, but to include in the work plan discussion a conversation about health information exchange, not the specifics, whatever we might need to get more details about later, but seems like we've had today and in other places a need to assure that there's better coordination through data availability. And that conversation, I think, could be a good part of a work plan discussion.
Oh, yeah. Okay. I don't see any opposition to that. Unless there
And
is.
if I can, Mr. Chair, I can remind the commission too that I think Dr. Slonim brings up a really great point, and it's really about trying to strike the right balance between identifying information that is readily available and maybe gaps of information that this commission doesn't have. But in kind of maybe a compromise between a formal presentation and information exchange, you can all send me information in which you want to share about HIE, and then I will just collect it all and then share it with the commission for your further deliberations at the next meeting. And then if it warrants a formal presentation or a request, you can certainly have a discussion about that.
Well, and one other thing that I need to put out there, I've gotten multiple emails over the last hour from people wondering what the heck this elusive work plan is that we're discussing. And so I realize that we may not be required to divulge the whole work plan, but I think a sketch or an outline of what we're talking about would be good, because if you're following online and have not seen what we've kept amongst ourselves, you have no idea what we're talking about. So.
Sure, and Chair, I would actually defer to our DAG, who I believe is looking into that. Some of this information is confidential in that it's provided to me, and I have a responsibility to maintain confidentiality with certain information. And if you all decide to deliberate on it or share it with the public, of course, that's a public document. But I would let the public who's watching and everyone who's sending in email inquiries to you or to the commission to know that we need to get some clarity as to whether or not that work plan is something that is up for a public document or not, especially considering that some of that information contained in there is confidential because it is shared with me, and I have a responsibility to maintain that confidentiality.
So would that be like an agenda item on the next to vote on transparency? I'm all for making the work plan transparent. So I don't know if that needs a vote.
I honestly think this doesn't need a vote. We need to decide on this and to create and share a document with the public. I mean, we're talking about transparency. I think we need to walk the walk here.
Yep, so, Mr. Chair, our DAG has raised his hand and he may have something to say on this. So if we can let him speak about this document.
Please.
Yeah, this is Deputy Attorney General David Gardner. The decision is whether this is a public document or not. If it's a public document, it has to be given to the public, period. If it's not a public document, there's a section of SB 544, Section 7, that talks about confidentiality. I need to do some research on it and this exact memo and compare if that is confidential under that section. If it is not, it has to be transparent. There's not a question on that. So I don't think there needs to be a motion or a discussion because it either is confidential or not. And I'll be able to find that out pretty quickly. I'll probably have an answer today.
Great. Thank you so much.
And I think we can do that. We're going to have at least 3 meetings where we're referencing this work plan. I believe the public and everybody needs to know what we're talking about. That's all. All right.
Mr. Chair.
Tony, yes.
I don't know if you're still entertaining items for the next agenda.
Yes, we are. We always are, Tony.
Yeah, for our agenda, I would, given the amount of discussion we had both pre-COVID and post-COVID, I think one of the more important things for our consideration and dialogue are the issues around workforce. Workforce challenges affect our ability to deliver on quality of care. They affect our ability and the cost and price of our healthcare, and they challenge access issues across the board, regardless of payer status. So I would love to have a conversation to some degree of depth around workforce issues in the state across disciplines.
Okay.
I really like that. And I
know a really good speaker for that, Tony.
Great. So the other thing that I was thinking about with licensure is, I think we had some of the doctors here talk about the medical licensing board and what that looks like in their issues. I'm a social worker and we have totally different issues from our licensing board. If we're going to jump into workforce and potentially licensure, I thought it'd be great to have like a chart of what the issues are that people kind of report into those licensing so that we can really understand, as opposed to just kind of like lumping them all together saying this is the issue.
And I think we could get data on that without a presentation. So
yeah, I think it would allow us to get down into the details of what actually we might recommend to do about some of those things. Somebody brought up the issue of reciprocity before. There are certainly other things around that we could help to advance in the state.
Okay. Other suggestions? Sarah, do you have enough information for the next agenda?
I think I do. And so, and we are all on the same page that the next meeting will take place not next Monday, but the following Monday. There's no change to the schedule is what I want to just inquire about.
Okay, yeah. Teresa?
Since, it was Jamie, right? Who presented today on ways to drive down healthcare costs. And sounds like there's consensus around transparency, which is great. I'm in support of, and some of the other things, but I do think it would be worth really talking again and maybe reviving this idea of a public option, how we get there. I feel very strongly about this because it all boils down to dollars and cents, especially for the patient. And I think that it would be worth our time to see why Sprinkle Care failed, and how those bringing that back and having a public option, maybe looking at the Washington model of requiring insurers to provide a public option might be the way to do it in the current financial situation that we're in.
Let's keep it on our radar screen at a minimum.
Chair, it looks like our DAG has raised his hand, so he has an opportunity to say something.
Okay. Is he there?
Attorney Gardner, did you want to address the commission?
No, I didn't have any statements.
Okay, great, thanks.
Okay. Any further discussion on this agenda item? All right, going to get you to lunch in a little bit, folks. Public comment, Sarah or Leslie?
I don't have anything at this time.
Great. And if I can ask any attendees, if you would like to speak during public comment, please take an opportunity to raise your hand. Okay, let's see. I'm going to call on Miss Katie Robbins first. Hold on one moment. Let's allow her to come into the meeting. Okay, Ms. Robbins.
Hi, can you hear me?
We can.
We can.
Okay, great. Thank you. My name is Katie Robbins, and I'm speaking on behalf of Planned Parenthood Votes Nevada. The devastating impact of COVID-19 has had on Nevada cannot be overstated, and we know how difficult the budgetary decisions were during the special session. The family planning grants in Nevada are a critical part of Nevada's safety net, and we know drastic changes in this funding would have only made women, especially women of color, whose communities are already disproportionately affected by the spread of COVID-19, more vulnerable during long-term negative health and economic impacts from the pandemic. While so many things in our world are changing, access to family planning services is a key aspect of personal autonomy and empowerment, and the need for such services has not declined during a pandemic. We want to thank the governor and the legislature for restoring $1.5 million in family planning funds to the budget and ensuring that family planning was a priority during these tough decisions. We stand ready to help Nevadans through this crisis together and look forward to continuing that work to ensure that Nevadans will have access to the family planning services and resources that they need. Thank you.
Thank you. Additional testimony?
Does not look like we have any.
Okay.
If you want to just wait a couple more seconds for folks that are on the line, if you want to take an opportunity to raise your hand, let us know that you'd like to speak.
And also remind you that you could submit testimony in written form to us as well.
Okay, Mr. Chair, I believe that concludes public comment.
All right. And with the conclusion of public comment, I believe we have no other business and we are hereby adjourned. Good catching up with everyone.
Thank you.
Thank you.